Mr. Greenstein. Don't act like this is new. You've been in that seat many times.
I like the idea of sticking with the budget for sure. Good morning, everyone.
It's easy to get distracted.
So I've got some opening comments. I'm Bruce Greenstein. I'm here with Louisiana's Department of Health, and it's great to see everyone here this morning. I've got it.
Let Ms. McGee do her presentation first. I apologize.
I'm just so excited.
I'll be really quick for you.
Great to see you.
All right. Yeah. All right. Again, I'm Julie McGee with the House Fiscal Division. Next up is the Louisiana Department of Health. So the budget recommendation for fiscal year 27 that's in House Bill 1 is just under $23.5 billion. On the left, you can see that there's $16.7 billion from federal funds, $3.4 billion from state general fund, and $1.8 billion from statutory dedications. On the right, you can see that Medicaid is almost $21.5 billion, which is over 91% of the budget. There's 9,658 authorized positions. Here we have the different sources of funding within the department. The main source of funding is the federal funds, the majority being from the Medicaid program, but there's also, the department also receives federal funds from the Community and Mental Health Service Block Grant, the Substance Abuse Prevention Treatment Block Grant within the Office of Behavioral Health, from WIC, and the STD and AIDS prevention programs in the Office of Public Health. The department receives $3.2 billion from state general funds and $1.8 billion in statutory dedications. MADF is the largest statutory dedication. It's appropriated a little over $1 billion in fiscal year 27, followed by the Hospital Stabilization Fund and the NOW Fund. The department receives $778 million in interagency transfers. This is mainly Medicaid funds that are transferred between agencies within the department. They also receive interagency transfers from other departments such as DCFS, DEQ, and Department of Education. Then they receive $778.4 million in self-generated revenues, primarily derived from intergovernmental transfers from public hospitals, parish governments, and hospital districts that's used for the Medicaid match. Here we have the overall funding change for LDH. You can see that total means of financing is decreasing by about $1.2 billion. This is mainly attributable to the removal of carry-forwards within the Medicaid program. There's one adjustment that we'll see when we get to the Medicaid portion of this presentation that's for $1.4 billion decrease, and it's removing Medicaid funds that were budgeted and obligated in fiscal year 25 and then carried into fiscal year 27, so they're being taken out of fiscal year 27. I mean, they were budgeted in 25, carried over in 26, and they're being taken out in 27. You can see the state general fund is increasing by about $97 million from 26 to 27, and this is largely due to new state matching requirements within the SNAP program, and then the annualization of the SNAP, TANF, and the disability services programs that LDH inherited from DCFS with the One-Door initiative. Here we're looking at the budget from the state general fund for each of the agencies within the department. You can see that $3.4 billion of state general fund budget, of the $3.4 billion, the Medicaid vendor payments, which is the Medicaid payments, are $2.5 billion. During this presentation, we'll provide a detailed analysis of Medicaid, the 10 human service districts, Office of Secretary, Office of Behavioral Health, Public Health, and the Office for Citizens with Developmental Disabilities. The detailed analysis of the other agencies are in the back of the presentation. We're not planning on going through them, but if you have questions, we can do that. Here's the total funding for each agencies. Again, you can see that Medicaid is about $20.5 billion of the $23 billion budget. Here we see how the expenses are broken out. Personnel services are about 3.5% of the department budget. Operating services are about 0.5% of the department budget. Professional services, 1.5%. And then other charges and interagency transfers are about 94% of the department's expenditures. We'll see more detailed breakdown on the next slide, but the majority of that is Medicaid payments to the MCOs. So here's the breakdown of the other charges and interagency transfers. The largest of the other charges being the medical vendor payments, which is $19 billion. This is payments towards the private providers. This includes the per member per month payments to the MCOs, the behavioral health partnerships, and the dental benefit program. You'll also notice $654 million goes towards Medicare premiums, $242 million for the Medicare clawbacks. These are payments the state makes to CMS for prescription drug costs for individuals who are eligible for both Medicare and Medicaid. $168 million for the Rural Health Transformation Program, and we'll take a closer look at that when we get to the Office of Secretary. And then $138 million towards personnel costs to operate the human service districts. personnel and operating costs for the human service districts. And then on the right is interagency transfers. LDH transfers about $240.1 million to OTS, $168.6 million of Medicaid funds to the Office of Citizens with Developmental Disabilities, $121.2 million of Medicaid funds to mental health units. This is looking at the expenditure comparison from 25 to 26 to 27. The expenses are decreasing by a total of $1.2 billion. You can see the majority of that is in other charges, and that is within the Medicaid program. Getting into the human service districts. So the human service districts and authorities are local governing entities that provide community-based care and treatment for mental and emotional illnesses. There are 10 different human service authorities throughout the state. The budget recommendation for the 10 service district authorities as a whole is $236.5 million. 64% of the budget is state general fund, 26% is interagency transfers, and that's mainly from the Office of Behavioral Health and Medicaid. And at the bottom, you can see the expenditures. 96% of the expenditures are other charges. This is salaries and related benefits and other charge positions that the districts and authorities have, and also contractual and operating costs. Here we have the spending history from fiscal year 21 to 27. The total funding is increasing by $4.8 million in fiscal year 27. State general fund is increasing by $6.9 million due to various statewide adjustments such as employee pay raises, increases in related benefits. There is an increase at the Northeast Delta Human Service Authority to replace fees and self-generated revenues with state general fund. Those funds are being used for 3 positions for inpatient facility for residential substance use treatment for up to 15 pregnant women with active disorders. Then there's also an increase at the Calcasieu Human Service Authority to replace a building damaged by Hurricane Laura. Interagency transfers are decreasing mainly due to align the budget authority with actual expenditures. Then there's a $750,000 decrease in federal funds at the Metropolitan Human Service Districts for the expiration of a grant, a community behavioral health clinic planning development grant. Then here we have the expenditure comparison. Again, expenditures are increasing by 4.7. This is mostly due to increases in other charges, compensation, employee pay raises, salary adjustments, and increases related to benefit changes in the retirement rate. So the first agency we're going to look at is the Office of the Secretary. The Office of the Secretary provides typical management and finance duties. However, this year they did take on new duties with the One Door Initiative and the One Big Beautiful Bill Act. If you look at the last 3 items on the right-hand column, the office is now responsible for the emergency support functions. In October of last year, the ESF 6 function was moved from DCFS to LDH. ESF 6 was mass care, temporary housing and human service. Then in fiscal year 27, the ESF 8 function is moving from the Office of Surgeon General to the Office of Secretary. ESF 8 is the public health and medical services. Next, the Disability Determination Services, or DDS, moved from DCFS to LDH in October. They evaluate whether individuals meet the criteria for disability. And finally, the Rural Health and Sustainability is a new section within the office. The Office of Rural Health is moving from Office of Public Health into the Office of Secretary. And then the department is receiving a multi-year federal grant that was authorized by the One Big Beautiful Bill Act. So there's a lot of adjustments. That's a big picture of what's going on. The budget recommendation for the Office of Secretary is $366.3 million. About 67% of that is federal and 21% is state general fund. At the bottom, you can see 63% of the expenditures are other charges. That's primarily related to the Rural Health Transformation Program. 25% of the expenditures are for personnel services, and about 8% of the expenditures are interagency transfers. This graph shows the historical spending within the office from fiscal year 21 to 27. As you can see, the budget significantly is increasing in fiscal year 27, and that's primarily due to the Rural Health Transformation Program. Here we have the funding comparison from 25 to 26 to 27. In fiscal year 27, the total funding is increasing by $209.7 million. State general fund is increasing by 11.6. This is due to employee pay raises and related benefits, also the transfer of the EFS 6 function from DCFS and the EFS 8 function from the Office of Surgeon General, and then the means of financing swaps to replace federal funds due to expired federal grants. Interagency transfers are increasing by $1.6 million. This is due to increase from this slide explains that. This is due to an increase from Medicaid for personnel costs and transfers from DCFS for the DDS and SNAP administrative functions. And then statutory dedications are increasing by $725,000. That's due to increase from the Rural Primary Care Physicians and Developmental Fund. And then federal funding is going up by $195 million. $175 million of that is the Rural Health Transformation Program. Then there's also the increase for the functions that's being transferred over from DCFS. Here we have the expenditure comparison. Personnel services are going up by 13 million. That's due to the transfer of services from DCFS and then from the Office of Rural Health and the emergency support functions. Also, employee pay raises are included in that adjustment. The increase is offset by decreases in savings with the vacant positions. The operating professional services are both increasing due to the transfer of services from DCFS and the rural health transformation. And then other charges are increasing by 182.3 million. 168.7 of that is for the rural health transformation grant. We'll take a closer look at it on the next slide. And there's also increases for the services transferred from DCFS and the Office of Surgeon General. And then the increases are offset by non-reoccurring costs. So here we have the Rural Health Transformation Program. H.R. 1, or the One Big Beautiful Act, authorized the Rural Health Transformation Program. LDH was awarded $208 million for the first grant a year. They're starting to spend the money now, March 26. We'll actually see the BA7 to increase their budget authority, JLCB, later this week. They have until September of 27 to spend the money. CMS will determine the grant allotment based on program requirements and performance each year. So over the 5 years, the state has the potential to receive over $1 billion for the program. The grant is 100% federal and does not require state match, and LDH is budgeted $175 million in expenditures for fiscal year 27. Some of the expenses, it's $42 million to modernize technology, $38.6 for workforce expansion, $30.2 for capital improvements, $26.9 to strengthen care through multimodal models, $25.2 for outcome-based delivery, $5 million for pharmacy and fitness partnerships, $4.5 for the procurement of electronic health records, $1 million for state tax credits, and then the last $1.5 million, $1.6 million is the operating cost to run the program and salaries and job appointments. Next is the Office of the Public Health. The mission of this office is to protect and promote the health and wellness of all individuals and communities in Louisiana. They do this by monitoring food, water, and fighting chronic communicable diseases. The funding recommendation for the Office of Public Health and for fiscal year 27 is $595 million. 61% of that is federal funding. At the bottom, you can see other charges make up about 52% of the expenditures, and salaries and other compensation-related benefits are about 25% of the expenditures. The average annual spending change from fiscal year 21 to 25 was about 3.5%, and that steep increase in fiscal year 22 was funds that were received from GOSEP and FEMA during the public health emergency. Here we have the funding comparison. There's a $4.2 million reduction in funding from fiscal year 26 to fiscal year 27. $993,000 decrease in state general fund. That's due to it's a net effect of increases from to OTS and employee payment raises. I want to say throughout this, there's a lot of increases and decreases for OTS. This isn't necessarily for one particular project. The division looked at what OTS was charging and realigned the budget based on actual expenditures. So a lot of these are just to realign the budget to what they actually need to be. The increases are offset by decreases to remove one-time funding for the phenamine test kits, decrease for attrition adjustments, and decreases for the relocation of the Office of Rural Health. Fees and self-generated funds are increasing by $2 million due to the increase of the Vital Record Conservation Dedicated Fund Account and various statewide adjustments. Then statutory dedications are decreasing by $2.7 million, and that's due to the relocation of the Rural Primary Care Physicians Developmental Fund. Federal funds are decreasing by $3.2 million, and that's due to the relocation of the Office of Rural Health and expired grants for the Louisiana Commodity Supplemental Food Program. Those decreases are offset by increases in various statewide adjustments. Here we have the expenditure recommendation, expenditure change from fiscal year 26 to 27. Personnel services are increasing due to employee pay raises and related benefits. The increases are offset by the transfer of the Office of Rural Health to the Office of Secretary. Other charges are decreasing by $13 million. This is due to the removal of the non-recurring phenamine pilot testing kits and the transfer of the Office of Rural Health. Interagency transfers are increasing by $7.7 million, mainly due to the changes in the transfers to OTS. Next up is Office of Behavioral Health. They provide behavioral health administrative community oversight along with hospital-based treatment. The budget recommendation is $490.1 million. 52% is state general fund, 30% is interagency transfers, and 16% is federal funds. At the bottom, we can see that expenditure categories, 34% is other charges. Majority of the other charges are addictive disorder, community-based programs, and statewide crisis hub. And then 37% of the expenditures are for personnel services. 17% are interagency transfers to the human service districts and authorities and other state agencies. Here we have the historical spending going back to fiscal year 21. The average annual spending change is 6.9%. Here we're looking at the funding change from fiscal year 25 to 26 to 27. State general fund is increasing by $14.9 million. This is due to means of financing swaps replacing decreased transfers from Medicaid due to the deficit of the Institutions for Mental Disease allotment and UCC budget set by CMS. There's also a decrease in transfers from the Office of the Secretary and the Early Childhood Supports and Services. Interagency transfers are decreasing mainly to realign the budget with expenditures. Here we have the expenditure comparison. So personnel services are increasing due to employee pay raises and increases in related benefits, and that is offset by the attrition adjustment. Other charges are decreasing by $9.3 million. There's a $20.3 million reduction in the budget authority to realign actual expenditures with the budget. Then there's an increase for the statewide crisis hub for the implementation of a pre-admission screening residential review software for early childhood supports. Interagency transfers are increasing due to increased transfers from OTS and the human services districts. And then the acquisitions were going away because there was non-recurring purchases. Next, we have the Office for Citizens with Developmental Disabilities. This is a single point of entry into the developmental disability system that oversees public and private residential services for people with developmental disabilities. They oversee several waiver programs. The agency also houses 2 facilities, the Pinecrest Supports and Service Center in Pineville and the Central Louisiana Supports and Service Center in Alexandria. The proposed budget for fiscal year 27 is $231.2 million. 76% of that is from interagency transfers, and this comes from Medicaid. And then 18% of the budget is from state general fund. At the bottom, you can see the expenditures. Personnel services are 66% of the total budget, and other charges are 13%. The average annual spending change from fiscal year 21 to 25 is 4.4%. Here we're looking at the funding comparison from fiscal year 25 to 26 to 27. There's a $5.4 million increase, $976,000. The net increase in state general fund, this is primarily due to increases in statewide adjustments and increases into to payments to OTS. Interagency transfers are increasing mainly due to adjustments to the personnel services and acquisitions. And here we have, looking at the expenditure comparison from fiscal year 26 to 27, the net increase is $5.4 million. The majority of that increase is personnel services for employee pay raises, retirement rate changes, and savings from vacant positions. Last stretch, the Medicaid. So Medicaid budget is comprised of 2 budget units, the Medical Vendor Administration and the medical vendor payments. Together, they make up the Bureau of Health and Service Financing. Medical Vendor Administration houses the Medicaid staff that determines eligibility rates, sets rates, looks at claims data, tracks MCO contract compliance, and investigates Medicaid fraud. They also now house the Economic Independence Unit. This is where SNAP administration, along with the FITAP and kinship care, are located as part of the one-door services. The medical vendor payments is the budget unit that payments for services come from, what most think of when they think of Medicaid. The funding recommendation for Medicaid as a whole is $21.5 billion. 75% of that comes from federal funds. 13% of the funding is self-generated revenue, which is intergovernmental transfers and third-party payees. Then 8% of the funding is state general funds. At the bottom, you can see 95% of the expenditures are other charges. This is payments to the MCOs, public hospitals, Medicare premiums for dual-enrolled individuals, and public-private hospitals. Here we have the Medicaid historical spending from fiscal year 21 to 27. The increase in 26 was due to the increase in state-directed payments to hospitals and physicians and increase in reimbursements for physicians. Now we're looking at the funding recommendation for the Medical Vendor Administration. Their funding recommendation is $952.4 million, or 65% is federal funds, 30% is state general funds. At the bottom, you can see that interagency transfers are 30% of expenditures, and professional services are 28%. Personnel services are 20%. The funding change from fiscal year 25 to 27 is $95.8 million. The state general fund is increasing by 86.6 million. This is primarily due to the increase in state match for SNAP expenditures. Part of the One Big Beautiful Bill Act, the state matching requirement went from 50% to 75%, and that starts in October of 26. Also, there's increased funding need for OTS fees and annualization of the one-door initiatives and transfers of services from DCFS. Interagency transfers are increasing by 5.9 million due to the decreases from the modernization, they're decreasing by 5.9 million due to the decrease from modernization of security fund and medical assistance programs fraud detection fund. And then federal funds are increasing by 15.1 million, which is the net effect of the decrease in federal funds from SNAP due to the program, the administrative match. And then the 26.5 million increase in need for OTS fees and the 23.7 million need to annualize the funds for the one-door initiatives from DCFS. Here we're looking at the expenditures for the medical vendor administration. So 28.1 million net increase in personnel services due to increase of annualization of SNAP expenditures, employee pay raises, salary adjustments, and the increases are offset by attrition and retirement rate adjustments. A 13.3 million net decrease from professional services. That's due to an $18.8 million decrease in the transfer of funds from the Office of Aging and Adult Services for the pre-admission screening. And actually, the funding is going to be transferred to the interagency transfer, so it's not really a decrease. And then $4.5 million increase for the Medicaid cost reporting system. Interagency transfers are $79.9 million increase. There's an increase in transfers to OTS of $53 million, and then a $19.3 million increase to the Office of Aging and Adult Services for the pre-admission screening and residence review. Then there's a decrease to remove prior year carry forwards. There's a $4.8 million increase to annualized SNAP expenditures and a $4.7 million increase to the Office of Behavioral Health for statewide crisis hub. Here we have the medical vendor payments. Their recommended budget is $20.5 billion. About 75% is from federal funds, 12% from state general fund, and 9% is statutory dedications. At the bottom, you can see 98% of the expenditures are other charges. About $19 billion that we've seen earlier is from the private providers, which is the MCO payments. Here we have the funding comparison of fiscal year 26 to 27. All means of finance are decreasing by about $1.5 billion, mainly due to the removal of the carry forwards that were budgeted. It's that carry forwards budget in 25 that's carried in 26 and being removed. That one adjustment is about $1.4 billion. State general fund is also increasing for the MCO adjustment and then decreasing for changes to the FMAP. And then federal funds have a decrease for the MCO adjustment and an increase for the FMAP rate. I'm going to skip ahead because it's easier to see it on this slide. This is all the adjustments for the medical vendor payments. So the first adjustment is that removal of the carry forward. The next two, we have a slide of their own, so I'll skip over theirs for now. We'll go through those in a minute. Next is the nursing home adjustment. State general fund is increasing by $8.3 million for a total increase of $26 million. Administrative rules in the Medicaid state plan allow nursing home rebasing every other year and inflationary adjustment on the non-rebase years. Next is an increase in the intermediate care facilities, similar to the nursing home adjustment, where every other year they get an inflationary adjustment, and that's allotted in the state plan. Next is the projected increase for enrollment in long-term personal care services. Then there is a $2 million decrease for the transfer of the Louisiana Crisis Response System to OB, Office of Behavioral Health. The adjustment for the dental benefits program is for the utilization changes, enrollment changes, and premium tax changes. There's a $4.3 million increase in the upper payment limit for the nursing facilities due to changes in the case mix index to a patient-driven payment model. Those administrative rules changed several months ago, and this is to budget in the change in the administrative rules. Increase in the PACE program for enrollment of 42 new individuals during fiscal year 27. There's a $2 million decrease of non-recurring funding for uncompensated care payments to inpatient psychiatric hospitals. And then there is a $1.6 million increase for 22 new rural health clinics and the annualization of 21 rural health clinics that were added in fiscal year 26. And then an increase of $21 million for the annualization of 750 community choice slot waivers that were community choice waiver slots that were added in fiscal year 26 throughout the year. So here we have the managed care adjustment. The MCO adjustment is decreasing as a whole. The total means of finances is going down by $208 million. enrollment adjustment, projected enrollment is expected to decrease by about 21,000 participants. This is due to changes coming from the One Big Beautiful Bill Act. It's the 6-month redetermination and then the community work engagement new policy changes. Utilization is increasing. This reflects changes in utilization of services covered under Healthy Louisiana. Utilization is increasing by 2.8% for non-expansion groups and 6.3% for the expansion groups. This results in a total increase of $554 million, but a decrease in state general fund of $75.3 million. Then the non-emergency medical transportation and home and community-based service directed payments, there's an increase for recruitment and retention bonuses for NEMT services and skilled nursing services. And then finally, the rebate adjustment. Drug rebates are projected to decrease in fiscal year 27. Rebates are collected to offset expenses, and they're indirectly affected by enrollment. So the overall net effect of the MCO adjustment is a decrease of $208 million. Here we have means of finance and swaps. So the FMAP rate, which is the federal match on the non-expansion group, is increasing in fiscal year 27, which means more federal money and less state money is needed. Then next is the Medicaid Trust Fund for the elderly. It's reducing based on REC projections. So the money coming from the fund is decreasing and the state general fund is increasing. And then the same with the Health Excellence Fund, the REC projections are down. And then the Louisiana Fund, the REC projections are increasing. So there's less state general fund needed. So the net effect of the means of finance and swaps is a decrease in state general fund of $24.2 million. And here is some policy changes that are upcoming because of HR 1 or the One Big Beautiful Bill Act that will affect future funding for the SNAP and the Medicaid programs. These first two are actually factored into this budget. They go into effect January 1st, 27. The Medicaid redeterminations will change from annually to every 6 months. And then the Medicaid community and work engagement requirement will begin, where able-bodied adults will be required to engage in community service, education, or have an income equivalent. And that's a new requirement for Medicaid. SNAP already has a work requirement, but this will be a new requirement for Medicaid. And starting in October of 27, the provider taxes will start decreasing. The MCO tax is currently below the maximum, so that won't be affected till October of 28, but the rate will decrease by 0.5% annually until it reaches 3.5% in 2035. And then the SNAP benefits, which have always been 100% federally funded, starting in October of 27, if the error rate is above 6%, the state will have to start providing 5% match on the benefits issued. The rate is the rate of issuing incorrect benefits, either too much or too little. If the error rate is over that 6%, that would cost the state about $95 million in state general fund. Lastly, starting in January of 2028, there will be a reduction in the state-directed payments. Currently, the payments are based on the average commercial rate. At that point, the payment rate would be 100% of the Medicare rate, which is lower than the commercial rate. That's it. Now I'll turn it over to Secretary Greenstein.
Thank you very much. You make a great auctioneer. Read so quickly. Good morning, everyone. Thank you. That was an incredible overview of a very broad programs and large budget. I have a couple remarks and then just kind of frame up the discussion about the budget itself and then be excited to have a deeper discussion about all the puts and takes in the budget for this next year. Over the last year at LDH, our focus has not only been on managing the programs we operate today, but on preparing the department for the future of healthcare in Louisiana. This means building an organization that is more modern, more integrated, and more focused on outcomes for the people we serve. It also means ensuring the resources entrusted to us by the legislature are used as effectively as possible. At LDH, we focus on three main areas: continue to do more with the resources we have, strengthen the LDH team, and reorganize the department for long-term success. As this committee knows well, LDH manages the largest budget in Louisiana state government. But what's often overlooked is that most of those dollars are tied to specific federal programs and healthcare services that support our hospitals, our providers, and Medicaid recipients. For the upcoming fiscal year, we operate under another standstill budget. The way we make this work is through a disciplined approach to management of federal match opportunities, careful oversight of spending, and a constant focus on return on investment. Over the last year, we've worked with you, the legislature, to expand Medicaid provider participation, strengthen fraud and abuse prevention efforts, and improve the way directed payments supports hospitals and community providers. All of these efforts are designed to ensure that every dollar, whether it's state or federal, is used effectively to support Louisiana's healthcare system. Over the last year, we focused heavily on recruiting talented leaders and building a team that combines public service experience with new expertise and fresh ideas. We're bringing in leaders who focus on innovation, operational excellence, and measurable outcomes while investing in the extraordinary professionals who have served at the department for many years. Like many governmental agencies, we have some systems and structures that were built decades ago. They serve their purpose at the time, but they are not designed for the modern healthcare systems we face today. So we're taking a hard look at how the department is organized and how our programs interact. We're modernizing our systems, integrating our programs that historically operated in silos, and improving coordination across areas such as behavioral health, public health, and Medicaid. Our goal is simple: create a more integrated, technology-enabled department that operates as one organization rather than many separate programs. Looking ahead, our focus remains clear. We're working to improve health outcomes across the state, reduce premature deaths, address rising healthcare costs, and modernize the system that supports care delivery. At the same time, we're committed to running one of the most efficient health departments in the country. I appreciate your partnership and oversight. I look forward to discussing the department's budget with you today and answering any questions you have. I just want to say, before we get into the Q&A, what are we doing here? What are we trying to accomplish? And just a few months ago, we had the opportunity to visit Women's Hospital to kick off a mobile mammography. It was an RV that has diagnostic equipment inside of it. And in getting prepared to give some remarks that day, we looked at how that would help our breast cancer screening rates. And I was surprised to learn that we're fourth best in the nation at breast cancer screening rates. Fourth best. So Massachusetts, Rhode Island, Connecticut, and then Louisiana. We usually don't finish that high except for college basketball, maybe, compared to those states. But when looking at the outcomes, death rates, we're between second worst to fourth worst in the nation. What is happening to our women? They're getting screenings, but dying prematurely of cancer. We have a saying internally, we don't advertise it, we need to work on the marketing of it, but we just say die later. We're all going to die at some point, but our goal in our programs, the immediate goal, is to have people more years of their life to spend with their families and in their communities and in their congregation. And in fact, as we've watched opioid deaths go up over the last decade, we've focused heavily on that, and we have very good results so far. In the last year, we've reduced opioid deaths by 31%. We've launched Project Mom, which focuses on postpartum women, so 1 year after giving birth. Accidental overdoses is the number one cause of death for that segment for women, and we're focused heavily. We launched with 11 birthing hospitals last month to make a difference, and we're clearly focused on bringing down cancer death rates. When I think about things that we could do in the department without new money, but just making our programs better, you think about when you want to have something accomplished, you try to make the process as easy as possible. And so women are finding it pretty easy. We do a good job on breast cancer screenings, but what we're not doing is making it really easy for a woman to get care. We have great oncologists and great hospitals here. The survival rate is incredible, but it's getting the bad news of a cancer positive screen and then getting the care. We want to make that as easy as possible. I've gone around to hospitals and said, give me the list of people that were notified. I'll drive to their house and explain to them in the morning what it takes and how we can bring them in and how we can help them. We want to transition from our not so good death rates to be as good as we are in screenings with survival rates. And that's just at the core of what we do in the department. And I just wanted to humanize all these very large numbers and the number of programs that we have to make it translatable for every person that's in our district and in our family and in our communities.
All right. Thank you, Secretary Greenstein. Members, I know that's a lot of information. I believe every single member in here could ask multiple questions, and we still probably wouldn't get through all 60 pages of that presentation. But with that, I want to highlight that on page 62, there is a list of the department contacts for the agency. And their offices are right across the street. And I have never been denied access to their building. Somewhat delayed, but never denied. I think they delayed me intentionally, though.
Just bring your state ID.
Yeah. Yeah, your pen won't get you in. I want to begin with the agency and how complex it is, and at the same time how simple you're trying to make it. There's been some changes, obviously, with the SNAPs moving from DCFS, and so I know there's going to be some questions. I already had a couple members that had to go to other committees that I think they're confused about which agency they're going to be asking questions, whether it's DCFS or LDH. And so if that happens, you can divert, and DCFS will be.
You can ask
next.
all the questions to DCFS.
So with that, I want to begin with the Rural Health Transformation Program. Obviously, members, we all know that the Big Beautiful Bill is going to play a significant impact in the state's budget over the forthcoming years. And today, it is our responsibility to begin preparing for those future changes so that we, in this term, don't leave the next group of legislators in a bad position. So with the Rural Health Program, my one question on that is on slide 25. So I got a lot of questions on it, but I'll be quick. Slide 25, the $27 million for multimodal models. Tell me what that is.
This is mainly value-based purchasing so that we could help rural providers, mainly rural hospitals, take risk. Oftentimes it's going to be upside risk, perform more efficiently, and be financial rewarded for doing such. There's several good examples today where rural hospitals are participating in value-based contracting with Blue Cross Blue Shield and doing well. It provides both incentive and then funding to do types of care that are not associated necessarily with an inpatient admission, but it could be managing chronic conditions outside of the hospital, getting paid for that, and also being rewarded for saving money. So that's the goal. We will be in the experimental phase. We're going to walk slowly together before we can run together. But this provides a great opportunity for us to work and build capacity across rural hospitals.
Okay. Slide 30. Got a couple questions on this slide. There's a $200,000 decrease, or I guess it's expiring grant for Louisiana Commodity Supplemental Food Program. What was that program?
Mr. Chair, Drew Moranto, Undersecretary, Louisiana Department of Health. I don't know specifically, other than we do work with USDA and the feds on commodity food boxes. Tom, do you want to?
I mean, I think y'all kind of see where I'm going. Everything I represent is rural.
Rural.
Yeah.
So the commodity.
Introduce yourself.
Tanya Joyner, Assistant Secretary, Office of Public Health. And so you were asking about the Commodity Supplemental Food Program. So this is the program where we provide food to seniors over the age of 60. And then the Pantry Soft which is in the budget, is a $200,000 to replace the funding that we're losing at the federal level. And that is for the actual system that tracks all of the food that's going out. It's a software that basically maintains and tracks all of our the comings and goings of the products.
Okay, so everyone appreciate, I don't care if you live in a rural area or metropolitan or urban, you all got seniors, and yes, they all do have to eat. On the same slide, the rural health relocation, let's see where that was.
Yes, sir. So we're moving that to work with Ms. Julie Foster Hagan, who is standing up the full rural health transformation program. So there were some existing programs in the Office of Public Health, and so we're just realigning those.
Okay. Slide 38. See, members, this is how easy it can be. There's a lot of questions in there, and none of us will get through all of it. The statewide crisis hub, there was 2 pages. There was slide 38 and slide 52. I'm going to try to just kind of combine these. What is the additional funding that's going to be used for in the statewide crisis hub?
It's standing up a standard phone number for mobile crisis. And so as this, for Medicaid, so as this service we're seeing more uptake in it, and Holly's here to comment. But we're really just trying to increase. So people talk about 988 plenty, but 988 isn't maybe what you need just right then, right? So it will, but I bring it up for this reason, because 988 will connect with this new statewide crisis hub to get you a warm handoff. But if you happen to have access to that information already, they can dispatch mobile crisis to you and your community.
Mr. Chairman, the theory here is to create and then complement a true continuum of care that does begin on the phone or on the phone to have the interaction with someone who can help you, a counselor, but it also includes modalities of care all the way up to an inpatient psych admission if necessary. And today it's quite spotty. There are gaps in between modalities of care, and this is the beginning of using crisis to help be the overarching modality of care so there are no open spots.
So the increase in the funding request, that will be utilized for that?
Dr. Holly Howitt, Interim Assistant Secretary for the Office of Behavioral Health. Yes, we want to make sure that we have great coverage with all aspects of our crisis response system across all regions of our state. We want to make sure it's robust and it's effective. One of the benefits from this will be to reduce emergency department utilizations and get people access to the right care at the right time.
Okay, with this increase in funding, will this provide suicide prevention for our students?
This particular funding is not dedicated to that. We do have other funding dedicated to that and are working actually right now on a federal grant called Zero Suicide. We were a past recipient and now we'll be doing another application for that as well, specifically for youth and suicide.
Okay, would you please, and I don't want to do it here during this time, but after this, in the next week or so, I'd like to have a follow-up meeting with you on that and that funding or any additional resources for suicide prevention for our students using the Crisis Hub.
And if we could just take 1 minute, can you just give an infomercial on 988? Again, I think it's helpful to never miss an opportunity because that resource is available to everyone in our state, no matter what. And even the degree of crisis, suicide on the most intense end, but it could also be substance use disorder, could be depression. You just want to say one other thing?
Yeah, please. Thank you. So we really are trying to create an understanding in our community across the state that 988 is for any kind of emotional distress and support, ranging from I had a bad day and I don't have anyone to talk to, so you can call, text, or chat with them, all the way up to what we were talking about, suicide and crisis, where we need to deploy a mobile crisis unit. It's a great resource resource that we have in our state. We want to be able to use it to its full extent.
Okay. My concern is students are less likely to pick up a phone and call you is what I'm concerned about. So I want us to have a further conversation because I think we're going to have to be very innovative in how we reach and provide access for those individuals to feel comfortable. And you and I are very comfortable calling somebody. I'd rather call you than text. I'd rather you call me than text me because I get tired of reading text. And often people speak in a language, and I don't know what all those acronyms are. KYK. You know, I learned that from the BART billboards. This will be my final question because we got a lot in the queue. The one-door initiatives to utilize the savings on for Medicaid, TANF, and SNAP. When do you expect to see those savings, and what are the savings we should expect?
Well, I view the savings on two sides. One is the programmatic side, where this bill gives us a fresh look at what it is that we do in state government. And in the department, we view both the SNAP as well as the Medicaid program as tools that help individuals move from dependence to independence. We want to provide the support necessary and working collaboratively with Louisiana Works to be able to build the capacity for people to lose their Medicaid because it's being replaced with Blue Cross Blue Shield and a good job. So we're actually seeing, as a consequence of a robust economy, decreases in the Medicaid rolls today. And this is very early days of one door, but because of the growth in the economy, we're seeing fewer people on Medicaid. Now, we want to support people to the extent possible, and then as they move forward, they generate tax revenue as well as not on our programs. But in terms of the programmatic piece, maybe you can talk about the puts
absolutely.
and takes.
So obviously what I think you're getting at, Mr. Chairman, is, we took over the SNAP program, and we still today have we have two eligibility systems and two staff. I've talked to the committee quite a bit about that. So the off ramp for that is a little complicated. We need to find a new system or kind of treat in place for where we are. And then obviously, due to attrition and efficiency, I think we'll be able to fine tune what's really needed in the field. But I do want to bring a couple of important points. With some of the changes in HR 1, we have a lot of work ahead of us in the community engagement space, or work requirements in Medicaid. There are already work requirements in SNAP. And so we're having to bolt on to our system now to be able to perform that work, which goes live January 1st, 27, so about halfway through the fiscal year. So in terms of timing, I can't commit to anything today. But I know that we've got to work on staff and stuff, as I like to say to my team. You said we can make it simple. It's staff and stuff at the end of the day. And I will tell you, just with all of the changes and activities that we've done to have some eligibility discipline in the Medicaid space, our eligibility staff is working incredibly hard and making sure members that receive a request for information are paid attention to.
Well, I'd like to highlight that, the error rate being less than 6% is significant, especially for future budget issues. And we already know that there's a $95 million increase in state general fund for the SNAPs. Part of its administrative program. But I do want to commend LDH or DCFS, the SNAPS program. As I appreciated, our error rate as compared to most any other state in the country is very, very relatively low. I think it was at 6.2, 6.4, something like that.
I think we're 8th in the country. Don't quote me, but we're close to that.
So you're right. DCFS ran a very good, tight controls program. Their eligibility team is fantastic. We are still around 7% today, and it's in the budget for accounting for the increase in cost on the state side for having an error rate above 6%. And when we think about the way that we're managing the program today, as Drew said, we're not moving as quickly as possible for systems integration. And that's because we're focused this year on bringing that error rate down below 6%. Now, we can't make any commitments today that it will end up there. The government shutdown definitely caused an outlier quarter, and it was during the measurement period. But we think that while the ball is circling around the rim, we like to commit some goalkeeping and swat the ball out and avoid having to pay the $95 million at all. We are right now running a pretty aggressive program, and I think we've been keeping it somewhat quiet, but if this works, it will be an excellent example of state government innovation. So three primary pieces. One is double down on training for everyone in field offices that do eligibility as a refresher and a reminder for the most disciplined way to do the eligibility determinations. Two, think about it as peer support. We have some offices that are at 4% error rate and some that are in the teens. We're marrying up those offices today to transfer best practices and help coaching. And the third piece, which I think is quite innovative, is cash bonus payments to eligibility workers that in their caseload have reduced the error rate under 4%. So primarily going to eligibility workers, and then for managers and regional supervisors. So there's alignment in rewards for bringing that down. If everybody won every bonus possible, it's still about 2% of the overall savings that we would be able to achieve through reducing error rate below 6% and then alleviating the need to ask for the $95 million.
Okay. I'm going to go on because we have several in the queue. Vice Chair Zarang.
Thank you, Mr. Chairman. Secretary Greenstein, Drew. Morning, guys.
Morning.
Fully appreciate the focus on outcomes, which is great, and hope that continues, obviously. But the other, in light of the fact that you're operating under the premise of a standstill budget, I'll just limit my head's several questions, but I'll limit it to one, and that is in regard to the HCBS services, home and community-based services, and the deficiency that exists, especially in light of the Milliman study that was done in October. I think you let legislators and everyone know there was a deficiency, and it wasn't included in the budget. And I know maybe you put some for retention and some other things, but is there a way that we can look at trying to address that deficiency, and what can we do to put some money in there other than just appropriate additional dollars?
Yeah, let's talk about that because this is part of a broader strategy. First of all, we're blessed by having great providers in the state and a great program, and so many both seniors as well as disabled Louisianians depend on this program immensely. And without the program, we would have more people that would end up in institutions. So the rate study that you're talking about didn't identify a deficiency. It was part of a three-part strategy. We did the rate study, which was concluded and reported out on February 11th. The second pieces were in a cost report study today where providers submit their costs in a cost report standardized format. And then the third piece is by the end of the year, around the end of the year, we'll have a new policy about what the next 5 years looks like in the program. And then we'll come to you with an ask for funding for that. What we've seen in the market is quite interesting. Every year, about 90 new requests come to the department to open up a new agency. And from 2022 on, we've only seen 10 closures. Now, around the country, we've seen, especially in the private equity community, a lot of roll-ups and acquisitions. So there is definitely value in agencies around the state. we like the idea of preserving the landscape that we have, where we could still have small providers that could be family owned and are really deeply enmeshed in their communities. And we also like having larger providers that are more maybe administratively sophisticated. But in the rate study that we're referring to, there's a lot of assumptions on the costs that include, and a large chunk of it is, providing health insurance for employees. However, many fewer agencies provide health insurance for compared to what the rate study cited. And that's why we're looking forward to the cost report to be able to reconcile the rate study, and then we'll be able to provide a recommendation for increase.
So you're saying you think you have sufficient funding in the HCBS service slot right now?
For this fiscal year,
Okay.
we're confident and comfortable with where we're at. I guess we're teeing it up right now for next year. Next year, expect for us to come in and ask for a change. Listen, it could be that there's enough money and we ask for a reduction. I doubt that very heavily. But we have to look at the data. I can't make any predictions. But I suspect just due to the complexity of patients and medical inflation, we'll come in asking for a little bit more and probably ask for some assurances that a healthy portion of any increase would be dedicated to worker salaries rather than just administrative costs for agencies.
Okay, well, that'd be good. And similarly, on ICFS, I think you've put in an additional $7 million to carry us through this year.
Yes, sir.
But it's not going to be recurring dollars. Obviously, that's going to have to be something we'll address, and we can always look at. At least you're getting through this year, which is important.
Yes, sir.
Thank you, guys.
Thank you.
Thank you.
Chairman.
Thanks for your attention on this.
Representative Baralt.
Thank you, Mr. Chairman. Welcome, gentlemen. Good to see you again.
Good to see you.
Good to see you.
A couple of high-level thoughts before we get into the details of the budget. Number one, I want to thank you for your outreach to the legislature. You've been very active and proactive in bringing us in, so most of us probably already have all that contact information because you have gone out of your way to include us in the conversation, so thank you for that. I also want to thank you guys for your DOGE efforts. We talked about this at the very beginning about when Taylor Barra was here, and he said, we were able to keep a standstill budget because of all the efforts that we've done at finding efficiencies. And so that makes our job much easier. So thank you very much for your efforts on that. It really is greatly appreciated. Last, I love all this one-door conversation. Love that. Okay, on to the specifics, though. Okay, on page 58, MCO adjustments. Just a couple of quick things on that one. I know that we noted that we have a reduced number of people who are on Medicaid. I think I even saw that we are down now to the lowest that we've been since 2016.
1.51 million.
So we think that we're around, I saw somewhere 35%, which is the lowest we've been since Medicaid expansion. So I know that's a partially good economy, which is very exciting. It's also partially because we've removed people who are ineligible. One thing I'm very proud of, it seems to me, at least from what I have heard, is that no one who is eligible has lost their benefits to this point, which I think is great. My question to you specifically on this, it looks like we've got a lot of reductions in the federal on the MCO adjustments, but the state general fund is still going up, even though we're dropping everybody. Could you speak to that?
Yep, happy to walk through it, Representative
Yep.
Baralt. So a couple of things happening in tandem. So we have more expansion individuals rolling off than non-expansion. So those have a more higher favorable federal match. So that explains most of the federal decrease, not all. But you also have utilization and trend that are going up. So 2.8% for the non-expansion group and about 6.3% for the expansion group. The other thing that's happening is your risk pool is getting quite small. And so you have potentially healthier members or folks that were not using as many services that are no longer in the program. Also, a net effect of that is a reduction in premium tax, which helps us fund parts of our budget. So we did have to have an ask there to offset that decrease.
Got it. I understood the first part of that. I did not know about the second part. So that answers that question. I also see on this page there's some conversation about the pharmacy. So this is just a high-level question. Are we starting to see any reduction in pharmacy costs because of the conversations at the federal level about reducing drug costs, or are we still seeing the other trend? When OGB was here, they commented that pharmacy is soon to exceed medical costs. And just kind of what you're seeing on that.
Couple of comments there. Rebates generally down. You have less claims. I know there's a lot of conversation about PBMs, and I'm sure the secretary may jump in. But one of the things we did on his first day was fire the single PBM because our managed care organizations and the department really had no skin in the game. I've talked about that here quite a bit, so I won't regurgitate. But the plans now have more ability to work in their network and hopefully drive down those costs. So it is not just paying a claim without any explanation as to what's going on.
So I'll just split a hair here on this. As you think about people and stuff, we think about prices and volume, especially in the pharmacy side. So we're seeing prices not move very much, and that depends on both what pharma offers as price and what we're able to address as rebates to come up with a net price. And then it's the volume. So as Drew is saying, when our base was 1.8 million, we had what we'll call many relatively healthy people in the expansion population. So we were getting 90-10 match on that population, and they had very low utilization of healthcare services. So whether they're going back to work or they were on the Mississippi Medicaid program and on ours, and we eliminated them as part of our DOGE effort. So we have less coming in from the 90-10 revenue, which you would say, well, it should be all savings. But it means that on a per patient basis, the rest of the population becomes a little bit more expensive. So in that case, their volume may look like it's a little bit higher, the number of drugs, of prescriptions that they take, and the price is staying the same. So that's why you're not seeing an incredible lift there.
Got it. Okay, thanks. HR 1, slide 60, I think it was. I noticed that one of the things that they emphasized heavily was the eligibility every 6 months. We were already doing that, though, correct? So we were ahead of the game.
We started that, I think it was Senator Cloud's bill last year.
Fantastic. Provider taxes. Mm-hmm. Big money for our systems. And a couple of questions about that. On the hospital side first, mm-hmm. How much did our systems, just ballpark if you know the answer to this question, did our systems receive in 26?
How much supplemental payment? Mm-hmm. 4.4-ish.
Okay.
Billion.
Okay. Have we started working on the 27 preprint for the hospitals?
In a way, very early stages. I will be working with the hospitals in early April to start going through that, and we plan to submit probably by the end of May.
Okay, that was part of my questions. Will the hospitals all be at the table?
Yes,
part of the conversation?
100%.
I got some.
I was at the LHA board meeting last week and gave a high-level update to that effect.
Very good. There was some concern from one of the hospitals that reached out that there was some inequity, some variances, and so there was a question about whether or not there will be an effort to equalize the variances among the hospitals.
Well, I would tell you that variances are usually driven by volume, not necessarily methodology.
Okay.
And so if your volumes are down and you have less room to collect a supplemental payment because you have treated less patients.
Makes sense. Do you anticipate a lot of big changes? I know 28 is going to be the big deal, but you anticipate
Correct.
A lot of big changes from 26 to 27?
I do not. I do not. I think it'll look relatively similar.
Okay. That's very helpful. Okay, on the physician side, mm-hmm. have we heard any updates on the 26?
We have not. We went to CMS in February, and it is still pending. We went in person.
Okay.
Late January.
Late January.
Yep.
Right. Okay.
And we did reach back out, but we have not heard.
Do we anticipate any changes to what was submitted?
I don't at the moment. None of the questions that they've asked of us give me an indication that there would need to be a change. But that's obviously subject to federal review still.
And will we start that 27 for them? We're waiting on 26 first?
Same time. Yes, okay. Same time as hospital. So those will work those will work in tandem as we develop the next preprints that we'll submit, early summer.
Okay. And so, question about how that is being, I know the hospitals are at the table for the other one. Who's at the table to negotiate and to come up with the plan for the physician side of it?
Typically, it's a combination. There's a lot of consultants that work with various hospitals and affiliated and contracted physician groups.
Are there any independent physicians at the table?
Not always.
Can I make that suggestion and request?
Yes, you can.
Thank you very much. I'd appreciate that. While we're on physicians, I've had a lot of conversations and concerns about the severe shortage and pending shortage. I know there's been some conversations with the Rural Health Initiative. I know that there is a fund, the Rural Primary Care Physician Development Fund, that's kind of rolling over to that. Are there other funds that are going to be included in that, and what does that look like in terms of using those funds for recruiting physicians?
Yep, I can talk about a few things that we're doing there. One, we're looking at some robust university partnerships, not just nursing, which tends to get a lot of focus. We're short many nurses in the state, but obviously your question's more toward physicians. The other thing that's really interesting that Julie and the secretary developed is something that we call the Rural Clinician Credit Bank. And so let's take an example of you need a specialist in Pearl River, and maybe it was a little hard to get them, and so you need a urologist, and they're coming on. Maybe that's not the most rural example, but just go with me here. So say the hospital system gets them to sign a contract. They were able to attract them with either a bonus or some retention pay with an employment commitment. The rural health transformation is going to enable hospitals to get reimbursed about 75% of that in the first year. And then it does taper off because the grant is really about sustainability. Julie tells me to say that a lot, but that I think is one thing that really can help bolster bringing on clinicians in rural areas.
Follow-up question to that, just for
If
giggles.
I can't answer it, I'll grab her, but I'll try.
No. I think that well, I don't know if you might know the answer. Does it have to be a hospital that's doing the recruiting, or if there's a independent group, rural independent group?
No.
They could
Just
also
from a rural area.
Yeah, just from a rural area. Clinic.
Might not
It could be
apply to me, but yeah.
Clinic, FQHC, et cetera.
And remember, we continue on the loan repayment program for physicians, primarily in rural areas.
And that's that fund that's moving over. Is that what?
That's right.
Okay.
Do you mind if I make a quick comment?
Sure.
Just lastly on this, we haven't thought about it specifically to physicians, but y'all know I love to talk about the Hero Fund.
It's on my list.
But we're also doing Rural Hero. And so I think that is going to give us quite a force multiplier as well to do some creative things to get physicians in the pipeline as well and help defray education costs.
Let me know if there's anything I can do to help with that. Okay. Reimbursement on the Medicaid for physicians. We got to 85%. My first question on that is, have you seen an uptick in physicians who are accepting Medicaid because of that?
I've definitely seen a utilization uptick. I don't have a number in front of me, but
But you have seen it?
yes.
Anecdotally,
Yeah.
absolutely.
Anecdotally, I would, just for the record, like to point out that in that up to 85%, the delivery fee did not go up at all. And
For obstetrics?
Correct.
Okay.
And just spoke with a physician this weekend, female from my area, who said she is going to stop taking Medicaid OB because the fee hasn't gone up. It's lower than it was 20 years ago. And just kind of for the record on that.
Understood.
When are we planning to go to, I know the plan is to get to 100.
Correct. We've started having those conversations. Obviously, it's subject to funds,
Sure.
which is there. If we had to do more of an incremental step, I think that's something that we're interested in talking about. If we can go 5% every so often to see if that's sustainable.
Okay.
But we're actively having those conversations, but we haven't made a decision about how or when we can get to 100%.
And is it safe to assume that once we get to 100 on that the physician-directed payment will go away?
Well, it will come down. It may not necessarily go away.
Okay.
At first, because that the ceiling for that 100% of Medicare is in even further out year.
Okay.
of when
Oh,
those
'cause it was
preprints
5%
have
a
to
year.
start phasing down.
Right. Okay.
But it is important to watch, in this case, the means of finance for getting to the 100%. And there are advantages to doing it in the methodology that we subscribe to today over plain SGF in the Medicaid program for non-expansion populations.
Say that again.
Yeah, so basically, when we did the 85%, and I testified here about it, we had money in the MCO line and also the stabilization fund, which helps us pay for the increase there.
Got it.
Yeah.
Okay, I'm with you on that. Okay, switching topics, and then I've only got one more after this. Nursing homes. They go up every year, correct? So we do the rebase, and then the next year we go up for giggles.
Inflation.
That's correct.
Inflation. Okay, so we've had a lot of conversations about incentivizing quality. Is there any money that goes to nursing homes to incentivize better quality?
I will say I'll be calling you personally pretty soon. There will be an announcement made over the next 2 months about a program that I think everyone here will feel very excited about.
Fantastic.
That will involve quality and incentives.
Excellent. I love to hear that. And then just one more question. This might be a Julie question as much as it is for either of you. And by the way, fabulous job, Julie. You did a great job. Do we pay, other than temporarily when a nursing home patient is transferred into the hospital, anticipating they come back, other than that, do we pay nursing homes for empty beds?
We do not.
So if there were more beds, would it cost the state any more money, theoretically?
In my opinion.
I know it depends on where those patients were before they got there, but just having another empty bed does not mean it costs the state any more money.
In theory, there's something called supplier-induced demand. And our programs, whether it's in OCDD or OAS, and this is where we get helping Louisianians move from dependence to independence. It's not just for those with a job. It's for those that are trying to live in the community outside of institutions. We've seen evidence from around the country in the literature that the more beds there are, the higher the percentage of nursing home placements are. So to some degree, not having an excess of beds continues to assure that those that really do need nursing home level of care go into nursing homes, and those that can be taken care of in the community are able to maintain their independence. It's a healthy balance.
Healthy balance is right. Fair enough. Last question. MSIP. I don't know where it is in here. How much did we get last year? I'm very excited about the conversation about incentivizing outcomes with that money. My one question is, if we don't give them the money because they don't meet the goals, where does that money go? How do we determine how much comes in? Just that conversation.
Yeah. So
Did I try and then you correct me?
sure.
It's going to test my knowledge here. We couldn't be more excited about the significant shift that MSIP from last year to this year is undergoing. It's been primarily a flow-through financing program with a quality bumper sticker on the back of it. This is moving this year to a full-fledged, 100% no participation trophy, outcomes-oriented quality program. Last year, our total was about $695 million. This year, the forecast is $715 million. There are measures, and we can share with you the individual measures and the weighting aspect for hospitals. The first 2 quarters as we get underway require attestation by the hospital CEO that they are making significant progress towards their goals, and that attestation will be enough for us. And we're working very closely with all the hospitals now. Starting on July 1st, 2026 on, you have to earn it or you don't get it. Now, let's just say, listen, we hope and our goal is that every hospital steps up. They're all attainable. And if they lean in and make the effort, they will be able to earn their bonus payments. So that would be the best case scenario, and that means our all Louisianians, not just the Department of Medicaid, the Department of Health for all Louisianians benefit from it. If they don't, we're already in conversations with hospitals and internally and with the networks to develop special projects that can be earned by hospitals for either new issues that pop up that we want to attack, special projects that we want to put extra focus on, and where investment is required. But we're not going to use it. We don't have spending authority to use it in other ways, so it'll have to be used within that program to forward the outcomes and quality improvement that we want to see.
Perfect. Love that. Thank you
That I
both.
do.
A+.
Okay.
That's all, Mr. Chairman.
Thank you, Representative Burrell.
All right. Representative Amade.
Thank you, Mr. Chair. Okay, again, I think that these questions should be easy. I'm really just going to refer to several of the slides. Let me go in numerical order. On slide number 9, I have a question that's not specific to slide number 9. It just happens to be the first place in this presentation where technology services is mentioned. So my question is, by the way, it's mentioned 10 times. So I guess every department and agency within your department. My question is, how are we doing with technology services? Are the amounts that I'm seeing in this budget proposal going to be ongoing? Like, should these be stable amounts, or are some of these amounts reflecting a major overhaul of technology systems?
Couple of comments, Representative Amade. So the amounts, at least from this year to next year, I think would be relatively stable. And I will call out specifically the $26 million that we needed, because we were underfunded in our OTS line when we took on the SNAP program. And so that's why you see that adjustment in particular. And then obviously the match is changing with the federal government. That's a lot of technology piece there. We have done a pretty robust look through with Evelina about ways to save. But I don't think you're going to see those change until we either replace and combine the eligibility system and eventually modernize our MMIS, which is our claims system.
Thank you, because I didn't know what MMIS stood
Sorry,
for.
I get the acronym accusation a lot. I apologize.
This is appropriations, where acronyms is the way we speak. But go ahead.
Medicaid Management Information System.
Thank you.
Initials.
There you go.
Okay. My next question is from slide 46.
Exactly. I've got my rule.
Okay. This is more general. Let's see. So Medicaid is about $21 billion of a $23 billion budget. And I apologize for not sending this question out a week ago, because maybe you'd have the answers today. But
Okay.
that's I was kind of busy
Try my
here.
best.
So I would like to know the $21 billion broken down. How much of that, what percent or what dollar amount of that goes to actually providing medical care, as opposed to other expenses like personnel or what have you?
I'd have to break it down in between MVA and MVP, because we have the staff and the stuff on one side, and then obviously the payment side. But just the MCO line is typically around $15 billion, and then you have the supplemental payments on top of that, which is for medical care. So that's the $4.4 billion that I mentioned, and then about 1.1 in physician. So that is all going to systems providers for taking care of patients.
Okay.
Because I mean, we pay the MCOs a per member per month, so what they pay out the claims on the other end, but we're obviously paying for the individual to have coverage.
Okay. Rattle those off again. I'll write them down.
15.4 for the MCO line, and then it's like 4.4 for hospital, 1.1 for physician.
Okay.
And you do have the 700, and I think it's 20 plus in MSIP, which we just talked about.
Right. So if I add all these up, I would get a ballpark figure that I could reasonably use to estimate
Yeah,
a
but I
percentage.
could also, I can give you the MVA.
Yeah, just
The MVA budget is, hold on, 86.5 million.
Million.
Excellent.
Okay.
Sorry, sorry, Representative Ahmed, that's just the SGF. 95.7.
Million.
Yes. Please keep in mind that MVA now also has SNAP. That's where it's housed.
Is this helpful?
Okay.
This is the MVA,
Oh.
but this is the MVA budget, the portion of the Medicaid, which he said it
I'm
also
just
has
looking at the
SNAP.
needs
So
assessment. Sorry. Go ahead.
Right.
Yes.
So it also has SNAP. So that's not really medical care. That's more.
Yeah, this
Nutrition.
this is the
This is
administration
the administrative
side.
portion.
Gotcha. Okay. Good. I will dig more deeply into that with.
I'm happy to go through it with you more.
Well, let's not do that right here
Oh,
because.
sorry, I was doing the change, not the
okay.
total.
Let's not do that right here. As much as I
Yes,
would
ma'am.
enjoy it, we might lose everybody else. Okay. On page 57. Oh, never mind. That one's been answered. Okay. That's my list. Thank you very much.
Okay, thank you so
That's all,
much.
Mr. Chair.
Representative Marcel.
Thank you. Thank you for being here. Mr. Secretary, I just have a few questions. Can we go to page 22? And I think I may have heard the chairman ask a similar question, but I didn't quite understand the $1.8 million reduction for early childhood support. Can somebody tell me a little bit about what's happening there and why?
Hi, Dr. Holly Howitt, Interim Assistant Secretary for the Office of Behavioral Health again. This is an IAT that for Early Childhood Supports and Services, which is a program that we launched in December of 2025 that we're very excited about bringing back. And so in 2025, the Office of the Secretary funded that portion of it. And so we're asking now that SGF take that up and continue to fund this really great program that's affecting children from birth to 5 and their families.
So we're asking to put it in the statutory dedication, or are we taking it out of the statute? Because it's showing up as coming out of the stat,
It's reducing the Office of the Secretary, and I believe moving it to the Office of Behavioral Health.
but the program is still staying and the funding is still in place.
That's correct.
Okay, I just want to make sure that's
That's correct.
clear. Okay. Let's go to page 30, which is the oversight of the commodity food program. Is that Ms. Joyner?
Yes, ma'am.
How you doing, Secretary Joyner?
Doing well. How are you?
So it's an expired federal grant,
Yes, ma'am.
but
Yes.
we're going to continue. Are we plugging in that as well?
Yes, ma'am. It's a portion of the grant that's expiring, and so we're supplementing that
Okay.
as a means of finance.
Okay, so when we talk about it expiring, is that something from the federal level that they're reducing overall to all the states, the commodity program?
Yeah, I believe it is, but I have to confirm that if it's for all states. I'm pretty sure it is, but I'll confirm that.
So from a federal level, we're reducing commodities to seniors, and we have to catch that slack in Louisiana. That's what we're saying?
This is it's for the food. Yeah. I'm sorry.
No, I'm saying, I noticed that it's a federal grant, so.
Yes, ma'am.
Apparently the grant is going away. My question is whether or not federal funds are being cut across the board to states. Is that funding? Somebody can answer that for me?
Yes, so it's a reduction in the administrative portion of the grant. that is being reduced by $200,000. And so that's the piece that we're asking to fund.
Okay. Okay, thank you. On page 87, the Office of Women's Health. I know the Secretary, you spoke a lot about the cancer screenings and what you saw happening there, where we were in numbers, but the overall outcome, health of women is still kind of dim for Louisiana. So help me to understand. Let's go to page 87. What do you see it? So talk to me about the spending that we're doing, because we're talking about outcomes and we want to change the trajectory of Louisiana. Talk to me about why this funding doesn't have more money in this office.
Our primary levers for addressing cancer, and specifically breast cancer, is in our hospital MSIP program, which it features as one of the major outcome measures. So we're paying for performance for our hospitals, and in the Medicaid budget overall, where the funding is quite high. There's in their outcome and quality program, there's also a big bonus to be earned for proper performance in cancer care.
But I mean, I hear you, and I'm not disagreeing with that. I'm just wondering, the budget for Office of Women's Health is decreasing.
It went down about $50,000. Mostly what's in the Office of Women's Health is personnel.
So it's just personnel.
There are a couple of programs. I'm remembering the TEMA grant that we worked on with CMS for transforming maternal mortality.
And that's where I was going with the maternal mortality.
Yeah, so I mean, a lot of the programs though do exist in other parts of the agency, and so the Office of Women's Health specifically is mainly staff.
And I'll say, as our new Surgeon General, who is an OB, is taking over this office, you'll see a far more robust approach to driving up women's health outcomes and addressing birth outcomes as well.
Okay, and that's primarily where I'm going with this Office of Women's Health, which I passed the legislation to create. So I would just want to make sure that we just don't have an office that's standing up and not addressing all of these issues, and making sure that we're putting the dollars there to make sure we have the outcomes that we need.
You'll see a very robust and a tripling down of activities in that office. I think you'll see a high watermark this year, and it will continue to go up from there.
Well, that's exactly what I'm looking for, a high watermark and a less number in mortality as it relates to women.
Completely agree.
And maternal. Okay, so 988, Mobile Crisis Unit. That unit that you all are standing that up, is that already ongoing, or
two separate issues? 988 is the phone number.
Right.
And you could call it at any time. We support it financially, and it is, even though it's a national effort, when you call from Louisiana, you talk to a Louisianian either all the time or almost all the time. They're a rollover for Surge. So that will continue to maintain and probably expand over time. We want more and more Louisianians to use it, whether it's a college student or a person that is SUD or someone else in crisis. For the crisis units themselves, again, this is
I'm sorry, I probably asked my question wrong. The crisis units that you all are doing, because I know 988 is already in existence, right? So talk to me about the crisis units and what are they going to do?
So the mobile crisis units, we've been standing them up for the past several years. There are still, unfortunately, some regions of our state that do not have mobile crisis units, either for children or adults. And so we've made it a goal this year to have all aspects of our crisis response system in place by the end of the year.
Are we putting additional dollars into that portion of the crisis units? So
we're not putting additional dollars in. As the Secretary said earlier, we're doing more with what we have.
You're doing more with what you have. So are we creating additional crisis units for the spaces that don't have them?
Yes.
How many do we have?
How many do we have? I don't want to misspeak because there's some that are coming online each day, but I can get that information to you later this afternoon.
Okay, and I think the chairman spoke on another question that I had. How do we get the information to the students who are committing suicide at a high rate in this state? How do we address that? Is there any connectivity at all?
I believe there is legislation this year by Representative Boyd to move from student IDs just having the 988 on high schools to moving that down into middle schools. And we think that is a really good idea. About the more times people see something, they will know to be able to use that. And again, also just talking to them about this is a more emotional support tool. And so you don't have to wait until things are beyond hope. You can start when you're just having a bad day. You failed a test. Your boyfriend broke up with you. You can start calling, texting, and chatting 24/7 and talk to someone.
Here, if I could just add, we don't have the answer, and we're in a terrible, terrible crisis. I could just say right now, we'll give you the highest commitment possible to work with the Board of Regents, the LSU system, the UL system, you and the rest of the legislature. We desperately want to provide as much help as possible. There are resources that maybe can be reallocated to address more on college campuses all across the state. We want to do that badly.
I agree with college campuses, but I'm like Representative Boyd. I think we need to start it at a lower level, the K through 12, and we also have. I've passed some legislation to give them some days off for those types of things, mental health, with the signature of the parent. And I don't know if that has resonated or gotten to the schools like it should have. Because when students are thinking of doing something or doing harm to themselves, they don't have time to go and make an appointment with a physician whom we also have a shortage of, right? And it's a long waiting list. So that was some legislation that I'd like to have some more conversations with you regarding students and what we can do to integrate some of these funds, or maybe, like you said, doing more with less. To move some of the funds around. And then on page 36.
More with the same. We don't want any less, but in a standstill budget, we're committed to do more with the same that we have.
Okay, on page 36. It's the nearly $8 million in the change of the existing operating budget. 7.6 million.
It's reducing IIT. What's the IIT reduction from? What's this?
I think it's over here.
And I noticed that part of the interagency transfer is from motor vehicle and the Office of the Secretary of 6.6 million, but
They're just swaps in, I believe, the stat dead, or because there's an IAT on the left for 7.4.
I guess the question for me is the budget. It appears that the budget is going down by $8 million for the Office of Behavioral Health. That's what it looks like.
I don't believe so, because
Doesn't?
there's a $20 million reduction in budget authority as well.
Okay.
In the middle.
Right,
So-
so there's $20 million to realign the budget with actual expenses. So basically, the budget was over budgeted for the expenses that they were having.
So it's over budget in 2026.
Correct,
And it was corrected.
It's being
You're
corrected in
correcting it
27.
going forward for 2027.
correct.
Correct.
So
We
they're
have
not getting
excess
a-
authority.
Okay, so they're not getting a reduction in
Right.
any services of
Right, it's just
nearly $8
reducing their
million.
budget authority that they didn't use.
Okay. So if they were budgeted $497 in 2026, and so what you're saying is they were over budgeted by $7.6 million, right?
It's a net of, so it's $20 million that they were over budgeted based on the historical spending. And then there's some swaps with transfers from,
So where does that money go?
I mean, it's a reduction in, I mean, it goes back to the general fund. It's a
It go,
reduction.
that's what I'm
Yes,
asking. Where does it
it's a
go?
reduction.
Because it was already there, right? It was in their budget. So it goes back to the general fund?
I'd have to see what the means of finance was. It's in IAT.
Right.
It could be for Medicaid. If it's connected to MVP, I'd have to look at that for you. I don't know off the top of my head.
I'm
Yeah,
just
yeah, I
curious.
understand. Yep.
I'm just curious as to what it does. And so
There's a lot of companion requests that happen because of Medicaid match. So we can pay, we have the federal authority sometimes in MVP, and then there's a companion in IAT to OBH or
Okay.
OCDD or OAS. So that does happen quite a bit.
okay, this is my final question. When they passed the not so beautiful bill, that I asked this question: was it going to cost Louisiana more money, and has it for your department cost the state more?
It will in fiscal year 27.
It's going to cost us more for the not so beautiful bill that passed.
The administrative match does change for administering the SNAP program.
And then we get $200-something million a year for rural.
I'm sorry. I asked
then-
this when it first passed, so I was just making sure that we're on the same page. That
There
of
are
what
puts and
the-
takes on this. So our net increase of cost is for 2026 somewhere, well, around the 95 million.
For 27.
For 27 rather. But then we bring in 208.4 million in additional revenue on the rural health transformation grant. So we look at the whole portfolio, what the net is. So there's puts and takes.
right, but as it relates to the SNAP program and other benefits that are reducing on the federal level, we're having to pick that up on the state level. Is that accurate?
In this case, there's no reduction in benefits, but there's a reduction in federal participation in the administrative costs of the program, and that's what we pick up.
Right. But we end up paying more money. Thank you. Appreciate it.
Thank you.
Thank you, Representative Marcel. Take a bite at a quick question. The dental managed care RFP, that's going to be coming out pretty soon, I think.
It's
Any
been-
idea when?
It should be in the next few months.
Next few
Vice Chair
months.
Zarang. Yep.
Okay.
We've been working with OSP to get that moving.
All right.
But it is our intention to get that out very soon.
Thank you. Question, Representative Tarver.
Thank you, Mr. Vice Chair. Just comment before I ask my question, and that is Chairman McFarland talked about the importance of talking to you guys about policy and things like that. And I just want to say, as a critic probably, appreciate your guys' willingness to sit down and talk. And I think that it's very important that we do that. And I'm saying that to your staff as well as to us as colleagues, that even if we disagree, it's still a lot easier to get move on and understand what's being done if we talk about it. And so I'm challenging myself as much as you guys and everybody. Let's talk about policy and things like that before we just start judging it.
We're in violent agreement on that for sure.
I'm sure you are. Speaking of which, I have a policy question after we finish before y'all leave, if you step outside or
course.
something. Just an easy question, really. But so, Chairman, Representative Barad asked a question about the 85% physician, and you talked about an incremental increase potentially being a solution to get to 100. And that, really, if you think about it, 3, 4, 5% or whatever you come up with, that's just like really an inflation adjustment that you factor into your cost of doing business anyway. So I'd really like to see if there was something we could do to make that happen. And what do you have anything built in to increase it this year, or there's nothing, just going to be 85 this year?
Correct. It would just be at 85 this year.
So, go ahead.
If it's 85% of the Medicare rate, Medicare continues to update the physician payment program. Every year comes out in the spring. It includes a productivity adjustment as well as a medical inflation adjustment as well as a policy adjustment. So typically, the medical inflation piece rides consistent from the Office of the Actuary within CMS. that's outside of the policy levers that the department.
And implying that inflation, I'm just saying that it's just an increase that you could phase in. It's a phase-in increase that you could do that would make a workable method of getting to 100%.
Yeah, I think you and I are saying the same thing because the legislation is, quote, subject to appropriation.
Right.
And so as we think about trying to bite off what that increase, needs to be from a financing perspective.
How much would 1% be if you want?
I don't know, sir. Not off the top of my head.
Will the
Okay.
rate go up as Medicare goes up?
So next question has to do with the waivers, the 750 waivers.
The slots.
Yeah, is that an increase of 750 or is that a maintain?
It was an increase.
Okay, thank you.
Yes, sir.
Increase.
Yep.
Good, that's good. And then you mentioned talking about the error rate. I guess on the SNAP. I don't. You know what I'm talking about when we say
Your
the error.
region's the best, by the way.
Huh?
Your region's the best, by the way.
Congratulations to my guys.
I think they're in the threes.
Oh, cool. Good. Well, does that mean they get a opportunity for a bonus too? Or?
They can still earn.
It does.
Sorry to interrupt.
So no, the $95 million that it's going to cost us if we don't get to. Is that already in? Is that in the budget? The
No, sir.
95, or it's
That
just
won't
we're gonna
affect us until 28.
Okay,
our
so it's
fiscal
not
year
in the current
28.
budget.
That's correct.
All right.
And we're really just trying to cost avoid that, obviously, because we would have to pay that portion of the benefit if we go over.
So that would be an increase to that year's budget going forward. I mean, like if you get this year, at the end of this year, if we exceed 6%, then the next year you would have the increase potential of $95 million.
My understanding is that they'd take it in year chunks because you'd still have the opportunity to reduce your error rate. And so you're paying for a portion of the overall state benefit is where the 95 comes from.
Yeah. Okay. I'll just try to figure out the technical application, but you guys can do that, I guess. Now, I have a question about, I don't know if you guys heard the LSU health science folks talking about emergency room, I'm going to say emergency room visits. On the reduction, they were reducing their emergency room visits. And there is a question about how much we can do that on Medicare to get that down. And there was a study, I think Acadian Ambulance and you guys were supposed to do some kind of study. Are you aware of what I'm talking about?
Yes, sir.
That we haven't heard the report on, or what the options and the opportunities were. And the biggest reason why I ask it to you now is because they mentioned in LSU Health Science that they were making some successful things. I forgot what they said they were doing, but there was a couple of things that they said they were doing. And I'm just, that report was brought to my attention a month or so ago, and I'd just like to know what the status of that report is in terms of being able to work on reducing the amount of visits. Can you help me?
We finished the pilot project and a study was completed. The results were somewhat non-conclusive, and each health plan was given the opportunity to subscribe to the program in order to meet their reduction in emergency department visit wishes. And thus far, none of the plans have signed up for it. And it's for the plans to avoid emergency department visits, therefore saving money, therefore increasing margin. It wouldn't be on the state's behalf. And we've tried to facilitate as much open discussion and opportunity for doing business together.
Would you, just only reason I mentioned it is because it was brought to my attention that they had not heard anything about that. So could you maybe take another look at the communication?
we absolutely
with them
will.
To see that
absolutely.
Maybe there's no participation because they haven't really been. I mean, I know how things happen. They didn't get the message that you guys had a message for. Here's a look. I know these numbers are astounding in magnitude, but they're made up by small amounts that just continue to add up. So this is probably a really small question I'm going to ask you, and you probably don't have the answer to it. You may have to get back to me.
Okay.
Well, my question is, how much money do we spend on advertising? How much does LDH spend on advertising? Do you know what I'm asking? Do you know?
I do. I mean, not very much. We do have a couple of federal kind of mandated programs. remembering what's like something My Choice or something.
Well, I just see,
but-
I drive around, and I'm a retail guy, so I notice billboards probably more than the average John Doe does. But I see a lot of advertising, and by that I mean noticeable. But maybe it's just noticeable to me because I look at advertisements. But I just wonder, what is it that we have to advertise as the Department of Health? Now, if it's a federal program that says, "Hey, y'all get this message out, and here's the money," I understand
That does happen. We have a campaign right now.
Here's the real source of my question. If we're advertising for people to be aware of services that are provided by someone, I guess my question would be, why is LDH, why is the state advertising that? Why wouldn't the beneficiary of the payment be the one that was advertising that program? You know what I'm saying?
Yep.
And maybe, look,
Fair question.
like I said, that may not sound like a lot of money, but it's still money. And
Let us try to answer your question, because I think it's an important question. It deserves treatment. So there are myriad methods that we try to put our word out for a variety of reasons. Some may be when it's open enrollment for health plan changes. And we do a fair amount, we'll call, say, free advertisement through social media and other channels. We have an FTE that manages our digital assets, and that's it. We don't pay for airtime or billboard ads. So on the Medicaid side, we're generally managing the open enrollment and health plan selection process. That's part of our responsibility in administering the program. Much of what you see is related to addiction services. Some of it is stat debt in gambling that comes in from taxes associated with peeling off from state revenue, and that's our responsibility to make sure we outreach to those that may be addressing gambling addiction processes. Through the federal agency called SAMHSA, that's within HHS, we receive a number of grants that specifically outline what we need to use the money for. We become the intermediary for that. And you might see managing vaping or other behaviors that we're trying to convince people to second guess and then stop. And that's where probably when I travel between here and the Texas border or towards New Orleans on I-10, those are the billboards that I see, and they're generally funded by federal grants for those purposes.
so, look, I probably don't agree with, for instance, if it's a gambling issue, then the gambling vendor ought to be the one paying for it.
They do, by the way. They pay 100% of those advertisements that we do. We don't use state general revenue for any of that.
So your answer is you don't use state general fund for any advertising from a PR type. I mean, from a marketing standpoint, from a marketing impression.
For that,
You can look. Once you do this,
we'll get back
if
to
there
you.
is an investment there, I'd like to know how much that is, and maybe it's $10,000 a year. I don't know, but the real question is, if it's $10,000 a year, is that something the state should be doing and not the beneficiary of that service that you're talking about? So that I don't want to make a mountain out of a molehill, but I would like to know.
We'll report back to you.
Thank you, though. I think my last question was on the SNAP increase. You said we're going from 50 to 75%.
That's correct.
And then I saw on page 52 there's 4.8 million. Is that the amount of increase from 50 to 75, or what is the cost?
42. It's 42 million.
42 million from 50 to 75. That's how much it's going to cost us.
Mm-hmm. And that's only for 3 quarters.
So it'd be 60 million then for the year.
Because it starts in October.
Okay.
The change.
Okay. Thank you. I appreciate your time.
Yes, sir. Thank you.
Thank you, Representative Tarver. Representative Knox for a question.
Thank you, Mr. Vice Chair. Thank you all for being here. I do want to go on the record and say that I had the great opportunity to meet with your staff on last week, much of which centered around some policy questions that I had, and they were very productive in their response, and we plan to have another follow-up meeting. So I want to thank them and give them a shout out for having that meeting. My question as it relates to slide 9, OBH, I'm assuming that's Office of Behavioral Health.
Yes, sir.
So can you explain to me what we're referring to OBH, patient transitional housing?
Sure.
Where are we looking at? Permanent supportive housing?
So, right here. Yeah, come on up. Oh, it's a facilities. Oh, yeah.
Good morning, Karen Stubbs. I'm in the Office of the Secretary. OBH transitional housing, sorry, Rep. Knox, here this direction, usually refers to the transitional housing from our specific state hospital, typically Elms. So as they're transitioning out after a stay from Elms, they might enter an FSTRA bed.
Elms? What is
Elms is our East Louisiana State Mental Health System. So our series of hospitals that are forensic. So you've been arrested, you've gone through the criminal court system, and there's different levels of legal commitments that result from your criminal arrest. And then you would go to our the one state forensic hospital. They have different levels. And so one of the levels is a transitional housing level. Again, these individuals have had a criminal history, usually pretty severe to get to Elms. So they're very purposely moving them into different levels of housing situations based on security.
So are you saying these are formerly incarcerated people or incarcerated people who are being transitioned from a medical facility to where?
Well, they're working their way back into the community. So usually these transitional housing units have a heightened level of security, but they're in the community. So maybe they've been in jail, and they get transferred to our basically secure psych hospital at Elms at East Louisiana, and then maybe they've gone into a less secure unit there, and then maybe they've transitioned into a housing unit that has a higher level of security, and then maybe they've gone down. So just a very gradual introduction back to the community. But yes, they have been incarcerated at some point.
I would like to have a meeting with you to get a better understanding of what you're really talking about, because it's not clear to me. Are we talking halfway houses or group homes, or are we talking actual facilities where we're paying $24,584,000?
It's all the above. So I've had the chance to visit each of these sites, and I have to tell you, it's something our state should be quite proud of.
Okay.
The facilities really represent an opportunity for those that have been arrested and then going to a state mental hospital that's forensic. And then after several years of rehabilitation and treatment.
Can I stop you right there? What state mental hospitals are you talking about?
Well, our Elms, the East.
How many
Louisiana.
are we talking about? Because I thought we only had 2.
One large system, one big hospital in Jackson.
Is that the Villa Feliciana and the
That's a
Lally
nursing
Kemp?
home.
That's a nursing home?
Yeah.
What's the name of the mental hospital?
Elms, East Louisiana Mental System.
Is that on here?
That budget would be included under the Office of Behavioral Health's budget. This particular slider just changes.
Okay, I think that's where I'm confused. So how much is that we're talking about, that budget amount?
Just for Elms?
Yes.
I have to get it for you, sir.
It's not on any of the slides?
I don't believe so. I don't believe
I think
it's
it's rolled
specifically
up.
called out.
Okay, let's move on. The Permanent Supportive Housing Initiative. Can
We can get some more granular information.
I appreciate it. While we're waiting on that, can we go to the next item, Permanent Supportive Housing Initiative?
Yeah, you want to come up? Yeah, where's Gary? Hey, come on. Here, just sit right here. introduce yourself.
Gary Williams, Assistant Secretary for the Office of Aging.
Nice to meet you. Can we talk about the Permanent Supportive Housing Initiative?
Yes, as it relates to this slide, I'm not sure what makes that budget amount up, but of course, permanent supportive housing is a program that is to transition those with physical or mental disabilities from nursing facilities or other institutions into the community with support that could be with budgeting, financial management, all of the different tools that they would need to remain housed in the community.
So does this address the homeless, unhoused crisis that we have in the state of Louisiana, particularly in my area of downtown New Orleans and downtown Baton Rouge and downtown Shreveport and downtown Lafayette? Can any of this $14 million be used to address that crisis?
Some of it can.
That's what I'm trying to get an appreciation of how much of the $14 million that we're talking about today that goes to those particular regions. And I'm asking that because if you recall last year, particularly in my city, the state propped up a $15 million transitional housing for about 60 days. And while I appreciate it and was in support of it, there was a lot of fair criticism and scrutiny for the amount of money we paid. A lot of that had to do with paying $15 million for 60 days could have gone to permanent housing and permanently housed the same number of people who was there. So I'm pleased to see that we're now looking at a line item that specifically addressed permanent supportive housing initiative at the level $14 million. My question is, how much of that is actually going to supportive housing in the regions that are most impacted? For example, downtown New Orleans, downtown Baton Rouge, downtown Shreveport, and downtown Lafayette. And if we're talking about supportive housing, are we talking about newly constructed properties, or are you sending money to existing permanent supportive housing?
A little bit of both, and that's why we're really looking at this program.
How old is this program?
The program was initiated in 2005. It was after Hurricanes Rita and Katrina is when the program was initiated.
Is it $14 million every year?
No, I'm going to have to get back to you on the exact budgeted amount, that $14.9 million, Representative Knox. But what I can tell you about the program is it's not just, I don't want the program to be misconstrued as just a housing program. Again, these are, it's a program that addresses physical, mental disabilities. They provide the wraparound services for those individuals to remain housed. I don't want it looked upon as just a housing, quote unquote, housing program in general. Is to address specific needs of those individuals, again, that are maybe coming out of a hospital or a nursing facility or a mental health institution to transition to permanent housing. Again, dependence to independence is what we're looking to address with this program.
I appreciate that, and thank you for that clarity. And I also appreciate what the Secretary stated earlier insofar as trying to be creative and streamline things. Some of the points or elements you mentioned as to how this money is used as it relates to permanent supportive housing also is covered under the Medicaid for mental health psych units at $121 million. And I'm looking at $85 million for low-income and needed care collaboration. And I'm also looking at another $20 million for addiction enhancement and accountability. And so my question and my concern is, how can we streamline all of those line items I just listed to address the homeless crisis that we have in our state, particularly in our city, because it seems to be enough funding to construct a whole new facility, at least in New Orleans alone, and I would imagine Baton Rouge would appreciate some of that funding. So when we're talking about addiction enhancements and accountability and $121 million for Medicaid for mental health psych units, I'm trying to understand and appreciate where all of that money is going, what facilities by name, and how much per facility. Can that information be obtained?
Yeah, let's
Yes.
swap it.
I would like to know, in particular, how much of it is going to my district in New Orleans. Because, Mr. Secretary, when was the last time you were in New Orleans?
Week before last?
Were you downtown?
Yes.
Did you see the problem that I'm talking about?
It was well aware to me as I drove around downtown.
I'm sure you can appreciate the governor has an appreciation to address that crisis. He and I are on the same page with that. Are you aware of that?
Oh, yeah.
Is there a time and date that you and I could set up to talk about how we could streamline all these line items, the addiction enhancement accountability, the Medicaid for mental health psych units, the low income and needed care collaborations, how we can streamline some of that to target some facilities? I know several state-owned buildings and city-owned buildings in my district of New Orleans that can be converted to the permanent housing.
I'd like to meet tomorrow if you're available.
I will make myself available
Okay.
for that. Do you have the discretionary authority to shift these funds? It's my understanding that you do.
So when we have budget authority to spend within a certain line, according to the legislature, then it stays in those lines. But we feel comfortable with a great set of policies to come back and ask for authority through a BA7 to switch monies around. Some of it, especially in these areas, are hardwired from grants from the federal government to be spent straight through. But a couple pieces I think are important. One is we're working very closely with the governor's office on funding that comes through from HUD specifically for homelessness. And HUD is prepared to make a significant change in their NOFO, the Notice for Funding Opportunity, in the way that states use the money to deliver homelessness services. We have been working on a concept. This gets back to Drew's sense of people and stuff. We think about places and services. That if we're able to procure, whether it's an existing building or infrastructure, a place that we can organize through the integration of Medicaid, could be SUD services, community supports, behavioral health services. We can create the constellation of services to help support individuals if we could find a place for them to live. We believe that the vast majority will qualify for Medicaid and for SNAP. Good coaching around going through eligibility processes, being able to get the benefits delivered to the right place, and then supporting individuals to then begin a process of a variety of therapies and vocational training, and then switch from living outside to have a place to live, place to eat, and a job to go to. That's our goal.
I love that goal. I love that vision. And as I look at slide 9, I see at least 2 line items that you probably have immediate authority to make a shift.
We'll take a look at it. Yes, we'll definitely take a look. And
just to add to that, it's my understanding and appreciation, you can correct me if I'm wrong, it only cost about $8 million to house about 54 people for supportive housing. So you have more than enough just in that one line item. And then when I look at line item for addiction enhancement and accountability, that's $20 million. So that can fund a whole facility in my district. Wouldn't you agree?
Well, first of all, I would say that each of the services here are oversubscribed today.
What does that mean?
We already have excess demand. There are more people that want and need services than we have financing to supply those services.
I think that's where my concern is, because I've never heard of this line item for permanent supportive housing initiative until today. And it perplexes me as to why I didn't hear it prior to today, because in my city and in my district, we have a severe crisis. That's ground zero.
For the most part, that's a program that's massively oversubscribed. We have people that are in facilities today that are looking to live in the community. This program was designed.
People, again, you're talking about people that seems to be conflating. When you talk about OBH patient transitional housing, then you're conflating the same patients to go under permanent supportive housing. Then you're conflating the same patients to go into addiction enhancement and accountability. I'm trying to unconflate it and get to the point of addressing unhoused individuals who are not formally incarcerated or been to jail before. I'm trying to get to those individuals
Before
who
they-
suffer
yes.
from mental health
Yes.
and substance use addiction, not just the ones who are formally incarcerated. I'm concerned about them, obviously, but
I am
the
as
way
well.
that I'm looking at these line items, there seems to be sufficient enough money to address all of those concerns. Wouldn't you agree?
Not necessarily. Like I said, our
Well, you don't
programs-
agree with it.
Our programs are filled up today. We don't have extra money or extra slots that remain open to just switch around. So for every person that we switch a program for, that means we're leaving somebody for whom the program was set up for today. You and I are on the same page, absolutely, that we should be doing more and we should change the state strategy today for providing care and treatment for people that are homeless today. And you have our commitment to work with you on that. I think you'll find for the rest of this year work that the governor's office is doing and work that LDH is doing. We should be making significant progress. We'd love to work with you on helping coordinate that.
Yeah, I certainly appreciate that. Can you elaborate more, or staff? I think I heard somewhere where we said there was 14 million or maybe 26 million that was carried over from the previous year. And I think my colleague Rep Marcel asked, where does that money go? And it was unclear to me as to whether it went back to the general fund or does it just linger around?
I'd have to check specifically because it says it on here as budget authority. So to me, it would mean it was unspent. But it could be federal. It could have been a grant.
So if it was
I'd have to get that
unspent and
for
if
you.
it's not federal, does the speaker, or I'm sorry, the secretary have discretion to reallocate it to another line item or program?
You would have to, or through BA7 with approval from JLCB.
If it's there.
If it's there. I'd have to figure out what the means
They
of
can
finance
know if
was.
it's there or not.
We'd have to look at it for you.
How
today,
long does it
tomorrow.
take if you know if it's there or not?
I can find out. We can get you an answer today.
I appreciate that. One more question I think I have here. Can you go back to the Villa Feliciana and the Lally Camp, if I'm pronouncing that correctly?
Mm-hmm.
Slide 9.
Yeah. On the right-hand side.
What are those facilities again? Just to be clear.
Lolly Kemp is an LSU hospital in Independence, and Villa Feliciana is the state's safety net nursing home.
Can you tell me, because I conflate the two in my mind, because I think the Villa Feliciana is in Jackson,
Yeah.
Yes, it is.
but we don't consider that the mental health facility.
It's a
anymore,
separate
do we?
one.
Where is the mental health facility?
Also in Jackson.
Also in Jackson. Can you tell me how many beds that facility has?
794? 695 beds.
Is that the only mental facility we have in the state?
We have Central as well.
Central State Hospital.
Central State Hospital.
Where is that located?
In Pineville.
How many beds is there?
I think it's 120.
Yeah.
160.
Come on up.
How many facilities did we had prior to that?
We've got the
Because it's
same
my
number.
understanding, I thought we had more than 2.
Here, introduce yourself.
Prior to when?
Introduce
Prior to, we just now having 2.
Albert Simeon Jr., Administrator of State Facilities. So Villa Feliciana, as we talked about, as I think we mentioned, we had 162 beds, and then the one in Central State in Pineville, we have 116 beds. Those are our only 2 psych facilities we have in the state.
Is that where the 121 million go to? 121 million?
Where are you referencing the 121 Rep Knox?
Slide 9. Where it says Medicaid for mental health psych units.
It says Medicaid for mental health.
Yeah, I'm not sure.
Yeah.
Slide number 9.
Yeah. We'd have to confirm that, Rep Knox. We'd have to confirm that number ties to those 2 facilities.
At the 121 million?
Yes, we can get back to you today.
So we're only talking 2 mental health facilities. It's my understanding and appreciation at one time we had about 4, if not more. Are you aware of that? Anyone at the table?
I was not here prior to other facilities operating.
Okay, so then I ask the question, are we looking to build any more facilities? Because I think in part, what is contributing to the homeless crisis that we're having, particularly in my city of New Orleans and what I see downtown that I have to walk through just to come to this building, that we have a crisis in this state. And I appreciate the governor being willing to address it because he showed that last year. And it's my understanding and appreciation that he is committed to addressing that issue, particularly as it relates to mental health and substance. So my question would be, with $120 million line item, you don't know how that is really being spent as it relates to psych units as you sit here today, correct?
Two separate questions. So I don't know how the numbers that are on this page were derived. We can tell you all the numbers about what it costs to provide care, what our facilities cost to run. So that's not from our side what the question is. I just don't understand the puts and takes on this slide.
Okay,
So
I don't either. So that's what I'm trying to get to the bottom of. Is there any plan to build new facilities?
So we're in discussion about needs analysis right now internally. You are absolutely right. The state, actually the entire United States over the last 45 years has gone from a institutionalization bias to a deinstitutionalization bias. We refer to it all the time as over deinstitutionalization. Each state used to have larger facilities and more facilities. Today, we don't have fewer people with mental health problems. They just live under overpasses. Mm-hmm. They live in shanties. And that's not how we should be providing care, going around once a month with some supplies or asking questions. We absolutely should be thinking about how do we put sustainable facilities together to be able to provide treatment and dignity to those people. I completely agree.
Yeah, I couldn't have said it any better, Mr. Secretary, so I appreciate those remarks and that foresight that you're having. As you're planning that, will you consider putting a facility closer to where most homeless people come to? I don't know too many homeless or unhoused people in Jackson or Pineville.
No, that's not where you find a locus of homelessness.
I'm perplexed as to why.
Well, that's our facilities.
I understand that. I'm just letting you know. It seems weird to me that we would put a facility in a location where there's probably zero homeless or unhoused people, as opposed to a location near Baton Rouge or Shreveport.
Well, let's get the funding first before we locate it.
Yes,
okay?
sir.
Yeah.
That's what I want to talk about. Thank you.
All right.
Thank you, Mr. Chair.
Thank you, Representative Knox. Next question, Rep. Egan.
Thank you, Mr. Vice Chair. Gentlemen, thank you for being here. And I'm surprised that neither one of you came up to offer a facility that we're trying to offer up in St. Tammany Parish to provide some of those services. Joking aside, most of the questions I've had were asked before, particularly relative to MSIP and the nursing homes. You gentlemen administer a budget that's larger than maybe some small countries or many states in the Union. So, I think since you're coming into those jobs, have done a phenomenal job. The big dog in the room of the budget are the funds that are provided and paid to vendor payments, primarily the MCOs. Mm-hmm. The MCOs determine how much money we're going to spend and what we get for that money, essentially. And the MSIP program has, I think, done a real good job in terms of looking at what they provide and how good that is. And what I wanted to ask you to speak to, Mr. Secretary, is, and I know that we've had some of this conversation before, some of the things that you have done other than the MSIP program, to use Drew's language, to have the MCOs have more skin in the game for both in terms of the amount of money that we spend and what we get for that. I know that you've done some things in redoing the contracts, but there are other things that you have done to make them have more skin in the game. And towards that end, what we look for in terms of increased value, increased outcomes, and lowering the cost of the healthcare in the state?
Yeah, so this year, starting in January, we took the MCO contracts and included a 3% withhold program, we'll say, because we hold back 3% of gross revenue from each health plan, which could be the difference between having a positive margin at the end of the year or not. We also, since July of last year, when we convened the Quality and Value Convention with hospitals, health plans, not just in Medicaid, but across the state, really to be the first statewide thinking about how we have to change our programs and processes to get better outcomes. And part of it was to determine which measures we were going to use and how we were going to measure them, and then how we would implement them. And again, those started in January of this year. They're robust. They are achievable, but they're a challenge. There's no participation trophies in the Medicaid program. You earn it and get the money, or you don't earn it, and so sad, too bad. And we brought on a chief quality officer to work directly with the MCOs, chief medical officers, and their clinical staff to be able to push those changes throughout the state. And we're doing that at the same time at the hospital level to complement them in the MSIP program. So we think together we'll be able to produce better health outcomes and reduce the long-term cost of the program for Medicaid.
Okay. Thank you very much. Yeah, appreciate all that you've done in that regard.
Thank you.
Thank you, Mr. Vice Chair.
Thank you, Representative Egan. Question, Representative Coates.
Thank you, Mr. Vice Chair. Good morning. Is it afternoon yet?
We're close.
Okay. So I had a couple questions. Let me get back to my notes here. For the Office of Public Health for water systems, so we have a lot of complaints and a lot of dealings with brown water and different water systems, and that's something that you guys inspect and monitor, correct?
Mm-hmm. That's correct.
Okay, so I guess my question is currently within that budget, like what is the funding for that particular program?
Yeah, so kind of a top-down approach, right? So we're the regulatory authority for over 1,200 drinking water systems in the state. And so that's a partnership of testing and inspection and engineering review, whenever a system changes, needs repair, et cetera. We also provide quite a lot of support during weather-related events to them.
Okay. So I guess, do we have enough staff? Do we have enough to handle because, we have non-compliance, or we have some systems that are, struggling. So are we funding this program enough to get where we need to go for public health?
Go for it. You're Mr. Water.
I would always love more. One of the ideas that I've had, I'm happy to talk about it. For some reason, I get roped into water quite a bit. I got to be the money guy and the water guy. Look, this is really where I wanted to go, though. I've worked with Ms. Joyner for a number of years, and, we've been thinking about almost like a tiger team, if you will, to try to really go in and do a more top-down assessment and connect, no pun intended, connect folks. There's plenty of systems that work with water sector, right? But there's plenty that don't, or may just need a leg up to talk to the neighboring system, or what does their filter media look like? How can they have a better system overall for their community and their ratepayer, right? And so I think the engineering team does a lot with what they have. If there's a will to send us, some more, I'll certainly take it, and they'll stand it up.
If I could just add, there's, I think, two sides of the question. The one is, how are we doing as a regulator? And I think we are protecting every Louisianian's ability to get the water out of their faucet the right way. The other half of the question, though, is are there smaller water systems that need more assistance, coaching, maybe some financial assistance on the short term to make some investments critical so that they don't need as much oversight and regulation? And I would say we've seen a lot of evidence that that's the case. In some cases, local systems and governing authorities are reluctant to increase costs to their consumers, which makes it difficult to put on, let's say, a new pump or upgrade filtration systems. That's something that we're not going to be able to force any local system to do, and we don't want to do that. We do try to make our regulatory, both authority and our actions, flexible to work with local systems all the time. We have, I think, this is some of the probably the best team in the country in terms of water engineers, and they love their jobs. And working with local systems is both fulfilling, but sometimes frustrating. And so I think we could use a team effort between the legislature, local authorities, and our both regulators and their sort of player coaches. We don't mind calling in plays from the sidelines and getting onto the field when necessary, but we have to maintain our both the discipline and authority as regulators, protecting the consumer first, and then we want to be as helpful as possible beyond that.
Yeah. So some of the things I'm also, just my observations too, is like you said, these local authorities don't want to increase monthly rates and stuff and add that pump or whatever, but they get to where then there's no choice or something happens and then it's forced, and then the ratepayers are going from $20 to $65 a month because they didn't do the maintenance up front, but that might have been just small cost.
Ounce of prevention could be worth a pound of water.
Yes. So okay, so I just want to have some of those conversations too going forward. And this is more policy, and we can do this off, is some of the free chlorine and how that's also affecting the brown water and stuff. You know, I've talked to some utilities, so if I can also have some discussion with you guys offline for that.
Yeah,
as
since
well.
we moved from 0.02 parts to 0.05, it's made a difference.
Yes. So so let's have a conversation about that. And then last kind of questions. So I just briefly wanted to kind of touch on this also for the home and community-based services, that study. Like, where are we for this next year looking at what that study had recommended?
Yeah, so as I spoke earlier, we have a 3-part plan. So before this time next year, we'll have the full policy recommendation for the legislature. It will be included in our budget ask. But the 3 parts were, 1, the rate study, which was released on February 11th. We're in the process right now of the cost report study. We'll reconcile those two, survey market dynamics, and then put together a fulsome recommendation to the governor and to the legislature, probably late fall of this year as we start to see the returns come in from the cost report study. The rate study analysis recommends $2.11 increase over base, but it doesn't take into consideration, it recognizes costs, but not all providers, in fact, not the majority of providers incur. So one big driver is the cost of health insurance for all employees. Very few are offering full health insurance benefits to their employees, which makes the overall recommendation incomplete without having the cost report study. And then we'll bring those together. We're going to convene. We just had a meeting with providers. Today's Monday, last Friday, I believe, talking about the same 3-part plan. We're going to bring more providers in throughout this process. We had a mini summit at LDH for providers and advocates to review the rate study with our actuaries, and we'll be doing this with the community throughout the rest of this year.
Okay, thank you. Thank you, Mr. Chairman. or Vice Chair.
Thank you, Representative Coates. Rep. Bagley for a question.
Thank you, Mr. Acting Vice Chairman. Good morning, afternoon, excuse me. I just have one question, and I don't think that you're the one that's going to answer it for me, but I'm going to ask you anyway, since you are the head of the SNAP, but you did mention SNAP a couple of times, and the one of the most impoverished parishes in the state is DeSoto. We had child protection. We had to get it back because they were having so many problems, and we got that back. They just closed our SNAP office. Didn't say anything about it, just closed it. And we're in kind of in a quandary now about how we're going to handle that, because we have a large number of folks that aren't being served. And so with all this talk about service and things we're going to do, I think, and I don't know, I know you don't know everything that goes on in all the stuff in LDH is too big, but I would like an answer to that, is why they shut the SNAP office down in DeSoto, and when is it going to come back open?
Yeah, that's news to me. I mean, it is a large department, but we do know quite a lot about what goes on.
Not blaming you, I'm just asking.
We'll get back to you later today.
That's great. Thank you. Thank you, Mr. Chairman.
Thank you, Representative Bagley. Representative Thompson for a question.
Thank you, Mr. Vice Chair. You mentioned early on, a few hours ago, that some areas of the state you hadn't been able to spend the time, effort, funding, what all might be needed. But you didn't tell us what those areas were within the state. Would you mind telling me about that?
I don't recall exactly what it was in reference to.
Well, that was several hours ago. But you said that you didn't, whether you had, I figured you didn't have enough money to deal with those.
So we definitely see disparities in health outcomes in different parts of the state. And
about those.
So we'll talk about where we see higher prevalence in cancer death rates, higher prevalence in diabetes and other chronic conditions, and those would be our rural areas. And receiving...
What did you mention?
Diabetes, chronic conditions, and cancer.
What area?
In rural areas.
Rural areas,
Yeah.
okay. That's what I figured.
Yep.
So continue with that.
Represents almost a third of the population, and we do a number of activities financially with rural providers to offer payment rates that allow our providers to exercise access to care for the population. The Rural Health Transformation Grant gives us a robust new tool that we'll have for 5 years. We've made commitments to our rural providers to maximize the amount of dollars in the grant to provide payment for infrastructure enhancement, building, upkeep, anything that the facility is interested in and is consistent with the grant authority. We're going to maximize that amount. We're going to work with our state universities to expand incoming classes for nurses, behavioral health, and allied health professionals that will be dedicated to both rotating through rural providers and then locating when they graduate into rural areas. We'll have a fund for, as Drew mentioned, to be able to provide reimbursement to rural providers that hire new hires, whether they're fresh out of school or they want to move from the big city and go back home or go to a beautiful place, and then sign-on bonuses and retention bonuses will be available. For rural providers that haven't been able to adopt technology because it's expensive and because it takes a lot to implement, we'll be covering the cost for new EMRs and other technologies that will allow our rural hospitals to be able to compete and perform on par with suburban hospitals. And then we have other programs that are specifically to address the the health outcome disparities such as cancer, diabetes, and other chronic conditions.
Well, I think it's a great idea, but it's been slow moving, and I hope that you'd put that in the rural areas so you could see what difference it would make a lot of difference.
I agree that historically still slow moving, but I'll tell you this office, there's probably been no other office moving this fast in state government history.
I would agree with that.
Yeah. We're very proud of what we've done so far, but we don't want any accolades until we produce results. Right now, it's just getting money. We haven't spent it yet. And then after spending it, we want to see the results, which will be people's health is better.
I think with the money that we have, we need to start that as quickly as we can.
I agree.
All right, thank you.
Thank
I
you.
look forward to that.
You bet.
If I can't get it, I'll get Knox to help me.
Thank you, Representative Thompson. Representative Lyons for a question.
Thank you, Mr. Chairman. Mr. Secretary, I only have one question. As it pertains to page 58 of the slide, again, that was several hours ago, but page 58, I only have one question. On that slide in the third shaded area, it talks about the NEMT and HCBS direct payment in the managed care organizations. It's $6.4 million for recruitment and retention bonuses for NEMT services and skilled nursing services provided under the Extended Home Health Program. Who actually gets that funding?
Representative Lyons, the information that I have on it was that it could be for a supplemental payment to each NEMT provider per vehicle with a max of $1,500 per month. The funding helps offset insurance costs and other rising costs on carriers.
So that's still in place?
It is. Yep.
Great. Okay. So is it applied for by the providers themselves? How do they initiate actually acquiring that?
I believe they would have to actually incur the experience, right, to prove on the cost side that is what they're experiencing. And then they would work with our office to get that through their carrier.
Okay, because for the record, I did that several years ago. And the question was asked to me, how do we, again, that was years ago, for new providers, how do they access those payments and what have you? Okay.
But I'll check on it for you, but make sure it's running properly, but I believe it is.
Okay, good. Good deal. Thank you. Thank you, Mr. Chairman.
Thank you for everything.
Thank you, Representative Lyons. Rep. Adams for a question.
Thank you, Mr. Vice Chair. Thank you for being here, Mr. Secretary. I'm from Jackson, and we're going to talk Jackson right now. Villa is the nursing home for people. Forensic, we have a wing at Villa that houses forensic patients. Who pays for that? Is that the intertransfer between?
Let us be specific on the answer. Just a moment, please.
Okay.
Oh, yeah. That's the sick bay beds. Go ahead.
I didn't ask the wrong question. Yeah. Oh, they
Good
got
morning,
to talk.
Karen Stubbs. I'm with the Secretary's office. Yes, there is an interagency transfer for the wing at Villa that houses those who would otherwise also qualify for nursing facility level of care but have more severe behaviors. So there's a wing, and there is an interagency transfer that occurs between Office of Behavioral Health to Office of Adult and Aging, where those two, the budgets are separated, unfortunately.
Okay.
So they send money back and forth.
Okay, ALMS. We have the two group homes that you were talking about. People from forensic or ALMS move into. Who's both?
So all of the different levels of care under the East Louisiana Mental Health System, that's why they call it a system because it has so many levels of care, all of that funding rests under the Office of Behavioral Health.
Okay. ALMS, you said how many clients, patients?
About 690.
Did you know at one time we had over 6,000 there? We had 6,000 people at ALMS.
Yes, sir.
And overnight we lost them. And that's Knox, that's where we wound back up in New Orleans, in Baton Rouge, in Shreveport. So we have plenty of land in Jackson, state land. Why don't we come and build? And then SNAP. I live close to the Mississippi line. When my people come from Mississippi, they didn't have any requirements on their SNAP card. They can buy Coca-Cola, they can buy Pepsi-Cola. Am I going to get in trouble as a retailer because I sell it to them, even though they have a Mississippi SNAP card?
That is a good question.
Valid question.
Let us get back to you if all SNAP cards have the same UPC code reconciliation.
Yes.
We will get you the answer, but I will also tell you, Representative Adams, that F&S, Food and Nutrition Service at the Fed, is responsible for the audit function of that. We are obviously an intermediary, but they would be the ones that would be looking at that, not the department. But we'll get you an answer.
Okay. And one more. Y'all said y'all look for fraud and all. I have people come into my store with Mississippi SNAP card, and the same person comes in with a Louisiana SNAP card. I mean, what they keep telling me, we check numbers, we do this, we do that, but
so let me say that over the last, say, 8 months, the work that we did in the Medicaid program to eliminate duplication, eliminate those that don't live in the state, has yielded, and we reported it earlier, $104 million in savings and reconciled our roles in Medicaid. We're about to do the same thing on the SNAP program. It's been done to some degree, but it's not complete. More work needs to be done today.
And y'all say, I've always been told the balance is, I don't know, average person receives $400 or $500. I have one lady that comes to my store. She has a $4,500 monthly budget. It is unbelievable. And I tell people, and they say, oh, no way. It is unbelievable.
It is possible that she has 16 kids and takes care of her parents and her husband's parents. So it is possible, but that would be the highest number that I've ever seen before. And we'll run a report to show what the frequency distribution at different award amounts. That I find surprising.
Well, they don't take their receipts. I'll bring it to you so you can see it.
Deal.
Thank you, Mr. Chair.
That's good government. Representative Freiberg.
Thank you, Mr. Chair. Thank you, Mr. Secretary and Mr. Undersecretary for this extensive presentation today. I have a quick question. We talked about suicide in youth, and we've talked about adult mental health services. Do we have anything in the budget that addresses youth mental health services, preventive mental health services for young people?
Yes, it's distributed throughout the budget. There are OBH programs and then myriad expenditure categories within Medicaid, which include for very complex kids, we call it the CSOC program, which offers a constellation of mental health and wraparound services to both the kid and the family to try to prevent exacerbation of problems. Then within the Medicaid program, all of the traditional behavioral health services are available and consumed. It's almost $1 billion of spending within the Medicaid program on behavioral health, with a large portion going to kids.
Do schools make those referrals? Where do those referrals?
For CSOC, they do a lot of the time. They'll make the referral.
Or families might make a referral?
Families and DCFS as well.
And DCSF.
Yeah.
Okay. Thank you. Thank you, Mr. Chair.
Thank you.
Okay. That's it. No more questions.
Well, we're available till 4 o'clock if you need us.
As I said on slide 62 is all your phone numbers.
Thank you, and thanks for the entire committee for your dedication and your care and concern.